So I want to thank all of our sponsors who really made today possible. Events like this would not happen without the generous support of our sponsors. So if you haven't already, please, during one of the breaks or lunch, visit with them. I would really appreciate it. And again, anybody who turns in their event program or passport with initials next to these logos will be entered in to win a raffle. All right, so the Parkinson's Foundation, really our mission is to make life better for people with Parkinson's. We have a heavy investment in research into better therapies and best practices. And then, of course, we also have quite a bit of funding that goes toward patient care and support services. So these are some of the ways that we impact your lives, both nationally as well as in local communities. I want to point out today, I believe we have some payer representatives in the room. These are patient advocates in research, and these individuals work closely with the foundation. They go through training in order to really raise awareness about research initiatives going on. Can any of our payer representatives who are here today stand up and be recognized? John. Lucky you. Thank you. So again, there are lots of opportunities to get involved on a national and local level, especially when it comes to advocacy efforts. And we'll get some of our local ones here in a minute. But these are some of other things that we do to impact lives. We host a Moving Day Walk program all across the country. I'm sure many of you participated in our Atlanta Walk this October. We have a global Centers of Excellence network all over the world. And these are really medical institutions that have a heavy investment in research, and they set the standard of care for Parkinson's treatment. I know Emory is our local Center of Excellence here in Atlanta, and then we also have a Center of Excellence in Augusta. So I love this picture, mainly because I get to see my mom. She's no longer on the website, but that is my mom right there in the middle. I got involved with the Parkinson's community after she was diagnosed with Parkinson's in 2013. And if any of you guys have not, has anyone here ever called our national toll-free helpline, 1-800-4PD-INFO? Anybody? Yeah, a few people there in the back. A long time ago. Well, it's still around. It's still great. We've actually extended our hours. So anytime you guys have a question about Parkinson's, medications, anything, the helpline is a really great resource, and it will help you kind of navigate some of those things. All right, so this just shows you a little bit about the impact that the Parkinson's Foundation has had here in the state of Georgia. As you can see, we've invested close to $2 million in research here in Georgia alone in the last 5 years. And then these are some of the statistics. 2,500 people have accessed care at one of our centers of excellence. I'm sure many of you, get treatment at Emory. That's one of our centers of excellence. And then, of course, in addition to all the local wellness programs and events that we host, we also provide free resources. Hopefully all of you guys in your chair saw the handout, the resource order form. Definitely take a look at that. And if there are resources that you are interested in, would like to order, everything is free through the organization. So you can leave that form with me today. You can send it in. You can also visit the website to order resources. So one of the great ways that we as an organization really support local communities is through our community grants program. So as you can see, Moving Day is really the primary source of revenue for that community grant funding. In Georgia alone, over the last 5 years, we've issued more than 22 grants amounting to over $200,000. Funding, aside from community grants, also helps to benefit research locally as well. And we are currently now accepting applications for community grants. So if you know any individuals or organizations that are looking to host a wellness program for Parkinson's, an educational program, please let us know. We really have a heavy focus on reaching the underserved communities through our community grants program. So it's a really wonderful opportunity. So, PD Gladiators. Who here has participated in a PD Gladiators Fitness Network class? Woo! Yay, PD Gladiators. So as many of you know, PD Gladiators merged with the Parkinson's Foundation in August. Our goal was really to develop sustainability. We wanted to make sure that these amazing programs that Larry and Ellie built would be sustainable and would be around for years to come. So we merged, and we are now one big happy family. If any of you guys haven't been to our new website, parkinson.org/Georgia is where you can find all the information about our fitness classes and local programs. So what do we do? In addition to doing all the things that we do as a national organization, locally here we have a big emphasis on exercise, which is why we're doing this program today. So we manage a network of community exercise programs. We provide education and outreach to the medical community. So Lloyd Spann is here, and he's going to talk about this in a bit. But we really try to get out to neurology offices around town to let them know that, hey, exercise is important, and it should be a big topic of conversation whenever you're seeing your patients. So we really are trying to raise awareness. So right now, our fitness network, and you should all have a schedule in your chair, our fitness network has over 60 classes a week that are specialized for people with Parkinson's here in Metro Atlanta. And we're about to train over 25 more fitness professionals to really work with people who have Parkinson's. So we're going to be adding to this network, which is fantastic. So these are a couple of the fun events that we have locally in addition to education. I know education's great, but it's also important to have fun. Some of you, again, probably participated in Moving Day Atlanta. Thank you for your support. We do have another fun event coming up in the spring, and it's our Good Vibrations event. It's a comedy show that will be down in Atlanta, and proceeds from that are going to benefit our local programs. All right. So now, I know that was long, and I'm sorry I sped through it, but I really wanted you guys I wanted us to get to the heart of the program. So it's now my honor to introduce our first speaker, Dr. Jorge Juncos, a man who really needs no introduction. Dr. Juncos is the Associate Professor of Neurology at Emory University School of Medicine and a researcher and clinician in the Movement Disorders Program. He's had over 30 years of experience in the diagnosis and management of Parkinson's disease and related disorders. So without further ado, and Dr. Juncos, I should also say, he was involved in PD Gladiators and has been from the beginning and is now on the Parkinson's Foundation Local Advisory Council, in addition to the APDA Georgia Board of Directors as well. So thank you, Dr. Juncos.
So good morning, and thank you for coming out in the heavy traffic of morning in Atlanta. And I'd like to thank Larry, Ellie, Annie, and the board of the Parkinson Gladiators here in Georgia for inviting me to participate, and it's for me a pleasure. And what we're going to do this morning is going to be answering the question above, which is why exercise and why the paradigm for the treatment of Parkinson's disease has really been changed dramatically in the last 5-10 years, in that exercise has become the number one priority in the treatment of Parkinson's disease, and it's equal to or has superseded the medications that we also use to improve the life of patients with Parkinson's disease, and we have succeeded at that as well. And my colleague Joash Lazarus will be covering that part of the talk. I'm going to focus just on the exercise. So these are my disclosures and sort of the grant support and so forth. They're not relevant to this talk because I'm not going to be talking about drugs. Dr. Lazarus will be talking about drugs, so we can skip through that. So the exercise questions we're going to be dealing with are some of it is the obvious question. Many benefits of exercise can be explained by the cardiorespiratory benefits of exercise, which have been known for years, and if that was the only issue, we wouldn't be here, because it's like saying you have two little holes under your nose. The cardiologists, the internists, and everybody else that worked with exercise have shown over the years the benefits of exercise in fitness, stamina, strength, and balance. If you know Parkinson's, which I know you do, you realize that Parkinson's affects fitness, stamina, strength, and balance, and many other things. So these motor symptoms, as you can see from the first line, are also affected by deconditioning and loss of the viscoelastic properties and elasticity of muscles and the health of joints and so forth. And when you have both Parkinson's disease and deconditioning, you have a dual effect, only part of which is affected by carbidopa, levodopa, and dopamine agonists, and that's the biology of dopamine deficiency. But the result of the biology of dopamine deficiency is an acceleration of these other things, lack of fitness, lack of stamina, strength, and balance. And what you're doing is you're multiplying that which comes with aging and deconditioning with the fact that you already have dopamine deficiency. So that normal aging, you get a little bit of that. With Parkinson's, it accelerates and it becomes more intense. And as you'll see in a moment, it becomes part of the total disability. So the first thing that exercise does, it addresses that secondary disability which accumulates at an accelerated pace in Parkinson's disease. Now, beyond the motor benefits of exercise, there are non-motor benefits as well. As you know, Parkinson's is motor symptoms and non-motor symptoms. So the non-motor symptoms are sometimes even more important. So exercise also helps these non-motor symptoms like listed there: sleep, mood, anxiety, autonomic function, arousal, and cognition. Doctors and investigators who work with Alzheimer's disease are increasingly aware of this cognitive benefit, this benefit on arousal and cognition that is also part of the benefits of exercise. Now, getting more into the specifics of Parkinson's disease, because you could argue, well, that's all well and good, but then we should all exercise. But it is particularly important in Parkinson's disease for the reasons we're going to cover here. And that has to do with the fact that there's also increasing evidence that exercise has neuroprotective effects in both the motor symptoms and the cognitive symptoms. And there are CNS mechanisms, that's brain mechanisms, that have been shown to be activated by virtue of exercising, which is not intuitive. Why would exercising your legs and arms have any effect on the brain? For those of you who exercise, you know that there's some effect on the brain. Makes you feel better, among other things. And what we've done in the last 15 years is demonstrate that, yes, there is an explanation for these perceived benefits. So in addition to the things in blue there, which are the known cardiovascular complications that are prevented, the osteoporosis that's improved, cognitive function, even mood and depression, sleep, constipation, and fatigue, all these things are known to be improved by exercise. Nothing to sneeze at, by the way, though all of these are extremely important. But in addition, there's evidence now that there's improved drug efficacy and optimizes the role of dopamine transmission in the brain with the receptors that you still have and the amount of dopamine that you may still have at those dopamine neurons that have survived. And even beyond that, there's evidence that there's a neuroprotective effect of exercise in Parkinson's disease, and that's why I put there really. So that would be the novel part of this talk. Can we demonstrate that that's the case? And we're going to start with the basic, the clinical part. What is the evidence that it's specifically helpful to Parkinson's disease, not to your cardiovascular fitness only? So let's start with something that's very concrete in this. Can we measure the number of falls before and after exercise? And we know that falls are common in the elderly. We know that patients with Parkinson's disease fall at least 3 times as much as patients without Parkinson's disease who have been, once you're age matched. And we know that in general about 50 to 60% of patients with Parkinson's disease fall at least once a year. Falls result in injury in about half the time. And once you injure yourself, your recovery is not swift when you have Parkinson's disease. So the orthopedic surgeon may say, look at that hip replacement. It looks beautiful, perfect, everything looks nice, but you don't feel perfect anymore. You do take a little dip down in the course of your symptoms, and although with physical therapy and exercise you'll recuperate some of that, you never get back to baseline, and the recovery is not as easy as that which the orthopedic surgeons are used to seeing, which is I just send them to rehab for a few weeks and we're done. I don't have to see them again, and they're not going to come back with complaints because I've done such a beautiful job. So falls-related injury are one of the top causes of morbidity, loss of independence, and increased health costs. This is particularly true in Parkinson's disease, although it's true in general. So preventing falls in the elderly, it makes sense that it's a high priority among all the healthcare systems and the planning boards of how are we going to intervene in disability in patients. And exercise is really fundamental to this effort at prevention as a public health measure. So let's look at the falls a little bit more in depth. With Parkinson's disease, you have abnormalities of posture where you lean forward without knowing, so that you ask the patient to straighten up and they straighten up so that they can voluntarily make the correction. But if you wait 15 minutes, they're already leaning again. And that's the loss of feedback, so that it's not just that you're doing it because you're lazy or because your muscle contraction is abnormal. It's because the normal feedback it's impaired. Just like the autopilot nature of your movements is also impaired, as you see in the lady here who's trying to play with the computer while she's walking. There are too many ringy-dingies going on at the same time. And the nature of Parkinson's disease is that you can't reconcile all these ringy-dingies or too many ringy-dingies at the same time, particularly when walking. So when you have frontal cognitive dysfunction and mild cognitive impairment, the speed and quality of gait are negatively affected by anything that involves dual task activity, like walking and chewing gum at the same time, the proverbial joke. This is very true in Parkinson's disease, and we can measure that. We can also quantitate it. And it turns out that the ability to walk properly while doing dual tasks is one of the big benefits of exercise, particularly the enriched exercise, where you're not only going past just the fitness part, but you're also enriching the mental processes involved in exercising. For instance, tango and Zumba, which is part of the PD Gladiator menu, boxing, where you learn how to throw a punch and still keep your balance and not overbalance in the process. So enriching the type of exercise you do goes towards restoring some of this autopilot functions that are lost with the loss of dopamine. Again, too many ringy-dingies coming out of the basal ganglia, they jam each other and they tend to block, as seen in, for instance, freezing of gait, which many of you are familiar with. It seems like everything gets locked up as you're trying to initiate gait or as you're crossing the door. Now, this is not something that everybody has, but it's emblematic of what I'm talking about. The ability to do too many things at the same time. Perception of the door or the elevator door open and initiating gait. That is just too much, and it tends to jam up the system. So additionally, with PD, you have an impaired autopilot function. You now must think about movement and proper posture. Things that used to come naturally are no longer coming naturally or smoothly to. So performing more than one task may lead to falls. That's the bottom line. And part of the goal of exercise is correcting that or helping that. So the interventions began years ago with physical therapy. The role of exercise is really extending the benefits of physical therapy beyond the 6 weeks that Medicare pays for it, and also trying to take that, making it into a change in lifestyle that will stay with you for the rest of your life. The 6 weeks of physical therapy is great, but if you stop exercising as soon as the physical therapist walks out, you're going to lose that benefit over the course of a month or two. So that the effort of PD Gladiators is that how can we make that into a sustained benefit over the course of life? And ultimately it involves a change in lifestyle, which is part of the mission of Parkinson Gladiators. Can we brainwash people to change your lifestyle in such a way that you're now taking care of your Parkinson's disease at the same time? Now, the internists will be very happy that you're also taking care of your cardiovascular health and your pulmonary health and every other aspect of your health. So they're very supportive of this. We're saying that this, with Parkinson patients, you've kicked it up a notch to specifically affect the Parkinson's itself. So how is that? I mentioned before that Parkinson's disease is a total of primary and secondary disability. So if I may go into the, whoops, sorry. So here you see Parkinson's disease stage 3, which is when you start having balance problems. And the triangle represents total disability. And then this is a disability without exercise, and this is disability with exercise. And you can see if you compare patients without exercise, they share the same primary disability due to dopamine deficiency. That's the base. But there's a secondary disability that forms the peak here of the triangle. That includes the deconditioning, the accelerated arthritis, etc. And that secondary disability is dramatically decreased with exercise. And we knew that for a long time. However, we now know that bradykinesia, rigidity, tremor, and postural abnormalities, the inability to autopilot, multitasking, and so forth, those are primary disabilities. They're also benefited by exercise. So not only can we take care of the death secondary, but we can also take care of the primary disability of Parkinson's, which is something that's novel and different from simply having hypertension or heart disease. So the tools to make that work have been put together by the physical therapists for a number of years. So there are multiple books, as you can see here, Rehabilitation Strategies in Parkinson's Disease. It is from these efforts that the loud and the big, the high amplitude, teaching you how to, instead of using small amplitude movements as is characteristic of Parkinson's disease, trying to push you to purposely increase those the amplitude of those movements, and it works. There's multiple data from that summarized in these books and others that indicate that these efforts do help. We try to incorporate that knowledge into the exercise programs provided by Parkinson Gladiators. So although we don't call it big and loud, there's a lot of, you heard the whoop in the back there, so that we're trying to incorporate some of that knowledge into the exercise programs. So these principles that are evidence-based have been codified now by the European Physiotherapy Guidelines in Parkinson's disease. The hidden here is the American Physiotherapy Guidelines. So it's a global phenomenon now. So all of these are been accepted, they've been reviewed, they've been shown to be effective in multiple clinical trials conducted primarily by the physical therapists, kinesiologists, and now they've been codified into the guidelines that we incorporate into Parkinson Gladiators. So what's missing if we have the tools and the guidelines? So what's missing is the difficulty to maintain the exercise intensity. Some of that benefit, part of the knowledge that we have, depends on intensity. Looking good in spandex and looking at yourself in the mirror is not enough to really affect this change. So that you need to reach a minimum of intensity that we can show in animal models, that if you exercise the rats up to a certain, you have to exercise it beyond a certain threshold to get the brain benefits of the exercise. And in the rat models, you can measure things like the receptivity to dopamine agonist stimulation in rat models of dopamine deficiency that we call Parkinsonism. And you can show that they respond better to medication, that the recovery from an injury from drugs that are meant to kill dopamine neurons is much more rapid and much more complete in the rats that have been exercising compared to the rats that do not. And I'll show you a little bit of that at the end. So how do you maintain motivation? How to make it available, convenient, and affordable? The PDNet is something that was developed in the Netherlands, and it encompasses a network for the entire country, much smaller than the States, but it's tremendously effective, where patients get taken by this network and encouraged to exercise as part of their health insurance. And health insurance is beginning to be a little bit more proactive at providing support for those patients who join some of these exercise programs for the elderly. I'm sure that we're making some effort at making sure that something like Parkinson's Gladiators is ultimately recognized by the insurance companies and supported in some way. So that's on the works. And then if we have all these things, but the doctors fail to remind the patients to go in and exercise and shift their paradigm so that they don't think of exercise only when they start falling 5 years into the illness, then we will have failed. So part of my job is to tell my colleagues that this is important, show them the data. I go into more detail from the last slide that I'm going to show you to convince them that this is not just good or nice, but it's fundamental to the treatment of Parkinson's disease, and that the time to start this strategy is on day 1 from the diagnosis, not on year 5 after they start falling and you're trying to stem the falls and the physical therapist finally tells you that they need to exercise on a regular basis. So that answers the last question there. Another thing that is not here that we are working on is to maintain that sustainability and motivation. We also need to develop some methods of accountability and self-tracking of the progress that you're making. I think that visual aids to show you how you're improving would be extremely helpful, and how to take advantage of the wearable devices and so forth to look at metrics that can be simply put together to show you where you were when you started, where you are now, and perhaps even while Larry, Ellie, and the board is here, showing some playful competitiveness among the groups. Like, you develop a prize at the end of the month for the most improved gladiator, etc. I think that all these things that involve personal accountability and some concrete metrics would also be very helpful to achieve these same goals. So Parkinson gladiators sort of recognize that, nothing, not one exercise fits everyone's needs or likes and dislikes, so that one of the emphasis has been in providing variety and custom programs that are designed to meet your needs, whether you're fully ambulatory or you need to be in a wheelchair or you need to exercise only in the chair, at least at the beginning. So they've adapted Tai Chi, Tango, aerobic training, the boxing, the amplitude training, as I mentioned, to fit the needs of patients with Parkinson's disease at different stages of disease. They are also striving to make sure that once you get the first part, which is the aerobic training or the fitness part, that we continue to build on the richness of the exercise to build capacity for this loss of autopilot that I mentioned before, where you have to keep enriching the process to keep you interested, engaged, and active. So Parkinson Gladiators provides this, and all of these treatments that they provide have been shown to improve the Parkinson's disease rating scale, quality of life scales, gait speed, rhythm, stride length, postural stability, ability to get up and walk, reach. Even fine motor dexterity is improved. So all of these are evidence-based programs. And the goal also is to not only keep the effectiveness, but make it sustainable, fun, and exercise routines. And not shown here is what I think the number one goal and the number one benefit that you get from this, which is the camaraderie, the social aspect of it, which is sort of layered on top of the aerobic, the richness of exercise, and the human domain, which is the making friends, being able to get together and so forth. And ultimately, that's what sustains the whole effort more than anything. I think the foundation is important because you need the evidence and you need to see the metrics improving. Hopefully someday we'll be able to show you those metrics so you have the visual impact of knowing that you're achieving your goals. So what is the scientific evidence that not only is this good to make you look good, to make you feel good, and to make your Parkinson's do better, but what are you doing to your brain? And so I'm going to go into it just a little bit. And basically in the animal models of Parkinsonism, we have shown that exercise improves goal-directed motor learning, through aerobic exercise in particular, and that's why the intensity of the exercise is very important from the word go. If you look at on the left here, and you start looking at the synapses and looking at the question, how about the response to medications that I'm taking? Wouldn't that be nice? So there's evidence that you improve neurotransmitter receptor density and the richness of the dendritic spines here, so there's more receptors available to respond to the medications that you're taking. So basically, whatever you're taking works better when you're in shape and exercising. And we've known that for years, primarily because of those patients who are exercising, we rarely have to keep changing their medications and adding more medications. So for those of you who are concerned about taking too much, exercising is probably the best way of keeping to a minimum dose of medication throughout the course. It also has a neuroprotective effect in terms of, we know that exercise increases the levels of trophic factors. Those are nerve growth factors that sustain the health of the neurons' blood flow. It improves the immune system, neurogenesis, and metabolism of those neurons, making them healthier and having them last longer. So you have receptor density and response to dopamine, improve the health of the neurons in general, and then augment the healthy firing of these circuits that we interrupt in the case of deep brain stimulation, but you can also affect them through exercise over a period of time. This is a little more difficult to measure directly, but it has been shown. It can be measured indirectly by looking at cerebral metabolism, looking at fiber density across the pathways that we're intending to affect when we put deep brain stimulators in. And ultimately, it affects behavior, motor behavior and cognitive function, especially executive function that we know is improved with exercise. And last but not least, mood and motivation, which has been known for years, and the psychiatrists use that a lot in terms of recommending exercise to their patients. So to end, this is the current paradigm, or at least a paradigm that we were trained in terms of treatment of Parkinson's disease, which is a diagnosis, start pharmacotherapy, controversy whether early or late. The bottom line is that you want to start as soon as you have symptoms that are worth treating. If you're doing perfectly well, maybe not. But generally, we recommend treatment in order for you to then be able to exercise more effectively and not get fatigued as quickly. So this was the current, or I would say now old, I should change this, paradigm, where gait and balance problems and PD exercise came later in the course of the treatment, here in red. So what's happened now is that this has been switched, so now the exercise therapy comes first. That's the first intervention. And then we start working with PT consult and then the pharmacotherapy with for motor and non-motor symptoms. But the exercise has become number one step in the treatment of disease. So someone who has very minimal symptoms, you could probably keep it at that level with regular exercise for a long time. And again, it has to be intense. And for intense, we always recommend that touch bases with your internist. Make sure that you're not, having angina and things like that that should be looked at first. So that's the end of the talk. And Annie, did you want us to? Is there any questions at the end? Right?
Yeah. Could you just discuss weight, person's weight versus
weight training, resistance training versus aerobic exercise. I think the ideal exercise is a combination of both. If you ask a physical therapist, a weight exercise, particularly weight training involving your legs and your core muscles, is particularly helpful for maintaining posture and balance. I would say weight with stretching. And they feel that strengthening of the core and the legs is fundamental to maintaining the balance portion of what I was talking about here. I'm sorry? Uh-huh. You're always better off the thinner you are. But if you look good, you feel good. But it goes way beyond that. And in Parkinson's disease is no exception. I mean, since the problem is sort of leaning forward, the heavier you are. I'm not putting myself up as an example, but the heavier you are, the more burden you're going to be putting on the back muscles there that tend to tighten in the iliopsoas, the paraspinal muscles, and that's what gives you this sort of axial dystonia that you see in Parkinson's disease. So the lesser the load, the better the posture.
How do you know when you're doing something intense enough? Like, you measure a heart rate, or is there another indicator?
So the way we do it in research is we measure the heart rate, and we try to push the heart rate to a sub-maximal. So we're not pushing you to the level that the cardiologist may push you for a short period of time during a treadmill test to stress out your coronaries. But you need to be at a sub-maximal level, which in general is about 70% to 80% of your maximal heart rate when you exercise at full intensity. And that can be calculated very easily by your height, weight, and BMI, and it can be programmed into your Fitbit or your wearable device so that it alerts you when you've gone to that level. And also it has a safety feature that if you start going way beyond that, it lets you know as well. And at the beginning, what you're trying to do is you're going to try to reach that level, and little by little you increase the duration of the practice. Again, this is something that is generally discussed with the internist to make sure that they can make recommendations that would be appropriate to you as an individual depending on your overall health. Hello?
Hereditary. You treated my brother at Emory. He was diagnosed at 45 with Parkinson's disease, but when he passed away at 60 in 2000, he donated his brain, and it was found out he had 3 neurological diseases of unknown origin. You were the only one he trusted at Emory. His name was Ronnie Posey.
Oh, yeah.
You remember
I remember him very well.
But he loved you.
Okay.
It was light years from the way he was treated as to what Parkinson's is now. I want to know for my children, if he had had Parkinson's, and my husband now has Parkinson's disease, what is the chance of hereditary Parkinson's disease for my family?
So I can tell you that if you draw a curve of, hereditability of a disease, and so that things like diabetes, hypertension would be on the top of the curve, Parkinson's is at the bottom end of the curve because you inherit the risk. There's some exceptions to that. There are some forms of Parkinson's that are clearly hereditary, where the risk would be a little bit higher on that curve. But for 80% of the patients, they're in the bottom part of that curve, you inherit the risk, not the illness. Whether you have the illness or not depends on the risk factor that you inherited and a number of other environmental factors and other genes that contribute to enhancing or not that risk. And it gets complicated enough that, as I can see, we don't have a genetic counselor in our movement disorder clinic, because even they would not be able to sort it out. But in general, it's not something that you want to worry your children about. If you want to tell them something that would be useful, it would be to start exercising earlier, because we think the earlier you intervene, the more the benefit you get. And there's in fact data to support the fact that people who exercise regularly have a lower incidence of Parkinson's disease than the general population. That lower incidence probably means that if they were to develop Parkinson's, they are developing much later and they're not being counted.
Well, my husband's just been diagnosed not long ago, and he's got his first set of weights when he was 12 years old. He's worked out all his life. So if he was going to get it, he probably would have gotten it years ago if he hadn't known.
So I think that's the explanation that we surmise from all the data, that he probably pushed it another 5-10 years from the time he would have gotten it anyway.
Thank you.
I think we have time for one more question. He's been waiting patiently right over here.
Okay.
This is a question regarding the disease itself.
I'm rather a neophyte in Parkinson's, if I have it.
Okay.
But is there a possibility of reversing the process through this program that you're talking about, or is it inevitably down the grade?
Or is there any possibility or evidence that you can slow down the process?
Well, I'm sure you can slow it down, but I'm wondering if there's a reversal possible.
I think that would probably be promising too much. It is still a progressive illness over time, but you can slow down that progression significantly with vigorous exercise, but not down to zero. So you're changing the slope of the curve, but you're not making it into a flat curve.
Thank you.
Okay.
Thank you so much. And Dr. Juncos, if anybody still has questions we didn't get to, could I take those at the end and maybe
Sure.
we could get back to you guys? I'd be happy to touch
I'll
base
be
with
here
each of
till
you.
around noon or so. And, okay.
Thank you so
Thank you.
much. All right, my notes have disappeared, so bear with me. But our next speaker, well, is Herb Mesa and maybe Brian Jensen, and they are going to be taking us through a boxing demonstration. How many of you guys have tried boxing for PD? Alan, I see lots of hands going up. That's great. So as you guys probably know, we have several boxing programs within the Fitness Network. There's one right down the road here in Sandy Springs, and it's managed by the Livermento Delgado Boxing Foundation. So Brian and Herb are Boxing for PD trainers. They have programs now at LDBF 6 days a week. So no excuses, right? And multiple times a day as well. So we really appreciate them being here. And now let's give it up for Herb and Brian.
That's all I get? Where are my people? That's all I get? Is that a little bit? That's so much better. So, like she said, we run a boxing program. It's right around the corner from here at Fitness Firm. It's a non-contact boxing program. Not really, because every once in a while we will knock you in the head if you put your hands down. I've been part of the program for about 3 years now. And a lot of the gentleman over here about the reversing of it, I can't say it reverses it, but from what I've witnessed with this program, I have seen the quality of people's lives change dramatically. I've seen people that come in that are shuffling their feet, and now we're taking big steps and walking around. So as far as a quality of life, Mark, hey, nice for coming. I've seen people's quality of life improve dramatically with the program. It's definitely a vigorous exercise program, and that's the key word there is vigorous. I mean, we really push you guys to work hard. It's not silver sneakers. We're definitely pushing the envelope and trying to get them to do more. With that said, we normally start our class with about anywhere between, it could be 10 to 15 minutes of a warm-up. A lot of times we do our warm-ups starting from the floor. We find that by starting from the floor, we get everyone to kind of flatten out and straighten out by starting on their backs. So when they stand up, instead of being hunched over, they're standing more erect. Then we'll do some light calisthenics, back and forth, jumping jacks, push-ups, squats. Then we also will set up stations, anywhere from suspension trainers, battle ropes, lifting weights, what else? I mean, everything. Everything that we do, I'm a personal trainer also. Everything that I do, what I call with the general population, is done in this Parkinson's program. We don't limit what we do with them. Of course, there's modifications, and some people's abilities are better than others. We split the classes up into levels 1 and 2, and then 3 and 4. 3 and 4 needs a little bit more personal assistance, so we always have a lot of volunteers, and if anybody in here wants to volunteer, get with Denise in the back, and she'll give you our schedule. That's the nice blonde lady standing over there. And if you guys ever want to volunteer, just come watch. You're more than welcome to. So with that said, I've got Dave, my beautiful assistant. Can I get you two come up here too, please? So you can get a little visual of what we do with the boxing program. We do the boxing with a number count. So depending if you're right-handed or left-handed, all right, depending if you're right-handed or left-handed, that's your lead hand. If I'm right-handed, I am an orthodox boxer. That means my right foot would be back. That's Dave. You guys, can you assume your boxing positions, please, so they can see you from that side? Thank you. Don't be shy. Don't be shy. Please don't be shy. So, yeah, there you go. They're in their boxing positions. You see the left lead hand is the first hand. The lead hand is your left hand for your orthodox fighters. We do everything with numbers. So everything that's odd number is going to come from the left side. Everything that's an even number comes from the right side. We're going to start off with the first punch, which is the jab. So let's see the one, please. Look at the jab. That's your jab. All right? So let's see that 2 times. What we find is with the a little taller. With the numbers and the counting, it makes you have to think. So let's see 1, 1, and then the right hand is the 2. The number 2, right? 1, 1, and then 2. Beautiful. There's 8 numbers in the sequence. We go 1 through 8. The number 3, which is the left hook. As you see, Brian is moving around, making him move while he boxes. A lot of times what we're doing in the boxing class, we'll have them repeat what we're saying. So not only are they working out, they're actually having to talk while they do it. So you're getting them to do 2 things at once. Sometimes we get crazy and we do 3 things at once. We're doing talking, moving, and hitting all at the same time to really challenge each other. And that's what they're doing there. They're moving at the same time as they're punching. Now, we're going to do a slip. So, come here, Zach. All right? So, if she's here like this, she's going to throw her 1, 1, 2 at me. I'm going to throw 1 at her, and she's going to move out of the way because she doesn't want to get punched in the face. Right? So watch, we go 1, 1, 2, slip. See how good she is at that? She's amazing, isn't she?
It's because he hits you.
It's because if you don't, I hit you with a noodle if you don't move out of the way. All right? So 1, 1, 2, she slips, and then she's going to come back with the right hand and then a left hook. Okay? Boxing is the only sport, thank you. Boxing is the only sport where you have to do offense and defense at the same time. So it really pushes these guys to work. As you see, Dave doesn't like to get hit in the face either. All right? So we're going to go back to you guys pair up. So what we do a lot, we'll do stuff like this with them, like one of the trainers will have mitts, but we also partner them up into partners and have them boxing with each other and doing the movement. So you guys do 1, 2, 1, 1, 2, 3, 2. 1, 1, 2, 3, 2. 1, 1, 2, 3, 2. Then slip. 1, 1, 2, 3, 2, slip. Beautiful. 1, 1, 2, 3, 2, slip. Good. Another move that we like to do to get you to incorporate your legs. I'm going to borrow Lloyd this time. You're going to roll for me, Lloyd. Okay? Please don't let me hit you in the head in front of all these people. Okay? All right. A roll is if I'm throwing a hook at his head. You got me, Brian? Roll. Dave, roll. I'm going to throw a hook at his head. He's going to roll under the punch. So now I come back this way. He's going to roll under the punch. And then he rolls under the punch. So now I'm getting him to move up and down. Now, when we're doing mitts and stuff, I'm going to trip on that. If I have 1, 1, 2, and I take a step, no, I'm going to take a step forward. He's going to take a step back. I come forward, he has to step back. I go 1, 1, 2 again. If I come this way, he's got to come this way. So it's like a little bit of a dance. We go 1, 1, 2. We're going to go that way this time. You don't dance for a while, do you? 1, 1, 2. We go this way. 1, 1, 2. Go that way. 1, 1, 2. Go back. 1, 1, 2. Come towards me. And that's part of what we do with them as a group. We do the agility ladder. We do a lot of stuff that focuses on your balance and your footwork. With boxing, your feet are just as important as your hands. So if your feet aren't moving right, your hands aren't going to be in the position to where they should be. So real quick, show them a little quick, just freestyle on the mitt. Sure. And we'll close it out with that. Thank you, guys. Appreciate your help. Hit him. Come on, Dave. You've got an audience here, man. Does anybody have any questions? No? Yes.
Can you start off with someone that has balance?
Yes, absolutely. Everybody in our group has standing and balance issues, some more than others, and depending on where you're at, it will work through, you can work through that. Okay? Any?
What about getting your level 3 and 4 to start on the floor? Do they do that?
When we have enough volunteers, yes. And that's the key there, the volunteers with the 3 and 4. The more volunteers we have, the more we can do. We'll do stuff, even practicing how to fall from close from the floor, and practice how to get up from falling from the floor. We do a lot of floor exercises that work on how to swing your leg over. Make sure when you swing your leg over, you don't put your arms underneath you, because then you're stuck and you can't get yourself up. So we'll teach you to do it so you have one hand out. So when you roll over, you have a hand so you can push yourself up. So we do work with getting up off from the floor.
The entire 3-4 class can be done seated, sitting in a chair. So
Yeah.
it's modified as being seated as well.
Mm-hmm.
So the repetitiveness or the different numbers, 1, 1, 2, 1, 2, 3, does that help with the brain be able to process?
I can't scientifically prove it, but we see it, and yes, we definitely see it. The improvement on people, the number recognition and doing it, and hearing the number, and it becomes instinctual. They hit a 1, and their hands just pop out, or they hear the combinations, and the combinations can be 1, 1, 2, 3, 4, 3, 3, and we run, so you're doing multiple combinations. So you're throwing sequences of punches that can be anywhere from 5 to 8 punches in a sequence.
Is there a fee associated with the therapy?
Yeah, it's like going to a regular fitness class. And again, if you have any questions on membership and joining, Denise is right there in the back. You should be happy. It's I think something like $8 a class. Huh? $9? It comes out to like $9 a class. And it's it's probably one of the better fitness classes. Even if you don't have Parkinson's, and we get a lot of people that come take our class that don't have Parkinson's, and they can barely keep up with the group. And, right? We got a lot of them, right?
But you guys also have an unlimited membership though, so you could, that's probably the biggest bang for your buck right there.
Right.
You could
And we
go
also
6
do,
days a week.
Yeah, and we do an unlimited membership, so if you do like a monthly membership, if you come as many times as you want, and we teach classes 6 days a week, so we have probably the most amazing thing about our Parkinson's group or our boxing class is the community we've created amongst this class. It's social hour and workout all at the same time. A lot of people even go out for lunch afterwards. We've even taken the whole group out for lunch sometimes after class. It's become a real, if you're not in class for more than a week, someone will be calling you and wondering where you're at, because it's part of the community.
Anyone else have a question?
Yes.
How many times a week would you recommend?
At least 3 times a week. At least 3 times a week. For you to really get the benefit of it, 3 times a week. But even if you're not boxing 3 times a week, you need to be doing something. Okay? And that means something every single day. So you can split it up, boxing 3 days a week, and do swimming once, do Tai Chi, do a dance class, but you need to be doing something every day. And it's not only doing the stuff that you do in a classroom setting, it's taking what you learn in these classrooms and practicing that at home. The stretches especially, the things with your hands, opening and closing, rolling your shoulders back, just laying on the floor flat is an unbelievable thing to do, and most people don't do that. And you don't stretch, so if you think just because you're going to come to a class 1 hour a week or 2 hours a week, that's not enough. It's got to be something that you do on a daily basis, even if you just take 10, 15 minutes of your day at home and practice some of the stuff that we teach you in class. Because everything we do in class, you can recreate it at home. If you can't do a squat, you stand between the doorway, and you can hold on to yourself to do a squat. Sitting and standing from a chair is one of the harder things for people to do. And guess what we do? We get up, we sit down, we sit in a chair, and we just sit there. No, sit in the chair, stand back up, sit back down, sit back up. Do that 15, 20 times.
And I know the Parkinson's Foundation, they have the Parkinson's Outcomes Project, which is the largest clinical study of
10,000 Parkinson's patients across the globe. And I know that one of their exercise findings was that people who started exercising earlier and a minimum of 2.5 hours a week are performing a lot better than their peers.
And we see it. We see it every day. We see it every day.
More questions?
He's come a long way in a year. Yeah, he's been in the program for a year, and we get a lot of folks that when they first come in, being diagnosed is hard for people, and a lot of people come in angry. Charles. All right, and within a week of them coming to class, their whole attitude changes. We have people that come into class that when they first came into class, you couldn't get them to crack a smile. And now they walk in the door and they're smiling from the minute they walk in the door. We've done our job. We know what we're doing is working for these folks.
How much of it do you think is the releasing of aggression, frustration?
Nothing's better than hitting things. Okay? Most folks don't get to hit anything. And right. And even on a good, right? And on a good day, I even let you hit me sometimes. We get in the ring with them, and we'll get in the ring, and we'll just have them throw punches at you and try to hit you. And you'll be surprised on someone who you think can't move around. When you give them an opportunity to try to hit you, they really want to hit you. Sometimes.
All right. Well, thank you so much. Let's give it up for her and Brian.
Thank you, guys.
All right, well that was exciting. Dr. Lazarus, that's a tough act to follow, huh? Our next speaker is Dr. Joash Lazarus, who is a movement disorders specialist at the Multiple Sclerosis Center of Atlanta. Before joining the Multiple Sclerosis Center, Dr. Lazarus was a fellow in movement disorders at the Emory University School of Medicine, practicing under Dr. Juncos. He's held several leadership positions, including Chief Resident of Education and Neurology at Emory, and has been involved in public policy over the past few years. Please help me welcome Dr. Lazarus.
Good morning, everyone. Thank you very much, Annie. My name is Joash Lazarus. I practice at the Multiple Sclerosis Center, which is a bit misleading because I'm actually a movement disorder neurologist trained under Dr. Juncos. Happy to be here. Thank you for inviting me and having me involved today. So Dr. Juncos really set the stage of how we manage Parkinson's with exercise and spoke a bit about it. I'm going to change the track a little bit and speak about medications and how they can form part of the overall treatment plan and how they fit in and where they fit in and why. And this is what we're going to focus on today. So what are the obstacles to exercise and mobility in Parkinson's? As we know, it's one of the biggest symptoms, and as good as exercise can be, it's an obstacle to getting good exercise. I'm going to focus on something called motor fluctuations. I'll speak about what they are, how we know they're an issue or problem, and new ways to monitor them, and then what medication treatments we can use or add on to the exercise to prevent them from hindering your function overall. And lastly, just touch a little bit on surgery and where that fits in and to the overall management picture. So very briefly, as we know, Parkinson's is caused by a lack of a chemical messenger that we call dopamine. And dopamine has several functions throughout the brain, but what's pertinent to Parkinson's is that the area of the brain where it's lost, and specifically that circuit, is implicated in movement and controlling movement. And so when dopamine is lost, the normal, fluid, smooth, well-coordinated movements become hindered, and all the symptoms that are typically associated with Parkinson's manifest as a result. So the bottom slide shows what happens in PD, or Parkinsonism as a whole. Those cells that produce dopamine begin to die, and the endogenous level of dopamine, meaning the level of dopamine that's produced in the body, subsequently declines as well. And when you reach a specific threshold that's individual to different people, different symptoms start to manifest, and that's when you start noticing the slowness and difficulty walking and tremor as well. It all comes down to the brain being unable to properly send the messages and process the messages that are specifically related to movement as a whole. So PD, as you know, is kind of a personalized experience, or as Dr. Juncos used to say, comes in different flavors. Every patient has totally different experiences different symptoms to some extent, and a different rate of progression, if at all. And with time, it becomes more and more difficult for the brain to process the signals that are responsible for movement, and so body movement is affected. And although it's variable, there's typical clusters or typical symptoms that we point to when making the diagnosis. And those are highlighted here. The postural stability is one of the hallmark features of PD, and just a term that we use to refer to poor balance, so impairment of balance, and then a difficulty in compensating when you lose your balance, so leading to falls. Rigidity is the clinical term that's often referred to for muscle stiffness. There's bradykinesia, or slowness in movement, and comes out in many different ways. Some fine motor tasks like dressing or eating or handwriting, and then walking itself can become slowed and more difficult. And the extreme form of that is akinesia, difficulty initiating movement at all, so like freezing spells, for example. And of course, tremor, the involuntary trembling of the limbs, is pretty common and well associated with Parkinson's. As you know, replacing dopamine is kind of the key to treating Parkinson's. It's the primary treatment modality we use. It's still the gold standard, and it has pretty good effects in replacing the dopamine and therefore ameliorating those symptoms. But after taking dopamine for some time, you might find that the usual kind of consistent and reliable response you get from a dose starts to change, and it becomes a little more unpredictable. And we refer to that pattern as fluctuations. They consist of on periods and off periods, and I'll talk you through what they are. So on time refers to the portion of the day when the cinnamon is working really well, or any levodopa for that matter. And you will experience that because the tremor is well controlled, your symptoms as a whole are less noticeable or barely noticeable, and the most important feature of this is that your function overall is pretty good. So your movement and mobility is good, and fine motor function is pretty good. But some patients then have what we call wearing off. So the response of that dopamine, or the response of any levodopa formulation, kind of starts to wane before the next dose, and the symptoms re-emerge. The tremor may come back before the time the next dose is due, or you may have difficulty walking again, or slowness. And this really represents itself in your function. So balance is unsteady, and maybe even falling occurs, or fine motor function is affected as well. All those things we spoke about, like eating and writing, we refer to that as off periods. And although this is quite variable, so some patients may never develop fluctuations, others may develop kind of milder degree of mild tremor or mild symptoms before the next dose is due that has no consequence at all. Still others develop very significant fluctuations, and it becomes the biggest part of their motor control and the motor disease. And so this is what it can look like. It varies in terms of what off periods can present with. And there's 4 types of these off periods. The first we refer to as a delayed on. So for example, if you're taking levodopa medication 3 times a day, you may notice the morning dose kind of kicks in and has an effect after 15 minutes or 30 minutes, and it's working really well after an hour. But the next dose perhaps takes an hour and a half to kick in, and you notice that you have lost about an hour of functional time. That's what we refer to as a delayed on period. Another time is a suboptimal time. So it may kick in a little bit later or kick in at the same time, but it has like 50% or 40% of the effect the previous dose had. Maybe you still have some tremor or slowness and a little bit of freezing that doesn't get better. A third type is a dose failure, where it seems like the medication hasn't worked at all. And it can be quite unpredictable, but disabling in some people, especially when it comes to like the balance and the gait symptoms. And probably the most frequent type of fluctuation or wearing off is referred to as end of dose wearing off. So we typically start, for example, with 3 times daily levodopa dosing, and in the beginning, what we're supplementing is good enough to compensate for the loss of that endogenous dopamine, the dopamine that's normally produced. And so the response is pretty smooth, and the symptoms are controlled throughout the day. But with time, as the brain produces less of its own dopamine and is more reliant on what we're substituting, you may notice that the doses are no longer lasting for 4 hours or 5 hours, and maybe the symptoms start to come back after like 4.5 or 4 hours. And that's typical of what we call end of dose wearing off. So the graphic at the bottom is really good descriptor of what patients feel like. They feel like it's a cyclical event, and their days are cycles of good function, which is the on time when the symptoms are well controlled and you're able to go about your day and do everything you want to, and then that fading effect, which can be either gradual as the dose is wearing off, or kind of abrupt as well, when symptoms suddenly reemerge and function is affected. And that's what we're trying to address when we targeting motor fluctuations. As a recap, medication management is just one piece of the treatment of PD. Dr. Juncos and the speakers before me spoke about exercise and therapies and why they're very important. Don't forget the psychotherapies and social services that also have a big role to play. And I'll touch a little bit on the surgical treatment as well. So in terms of the medical treatments, there are several classes of treatments and drugs that we use. But I want to point out a kind of important point before we get to that. It was introduced earlier that exercise has what we call a disease-modifying effect. So the process that's ongoing in the brain really stems from accumulation of an abnormal protein, a bad protein that affects the metabolic processes within the brain. And exercise may have some impact in slowing down how that process progresses within the brain itself and when the symptoms begin to progress. To our knowledge, most of the medical treatments that I'm speaking on today are symptomatic. So while they do hide the symptoms to some extent, they don't have, we think anyway, a direct impact on the process that's ongoing within the brain at the cellular level in terms of the toxic protein. Having said that, they're very effective. And if all those symptoms are a hindrance to getting good exercise and then your overall health, these medications can keep them at bay and keep you active longer and allow you to sustain that level of activity, both functionally and from an exercise standpoint. So we have several classes of medicines that we use. The graphic on the right illustrates roughly and simply where they act. Levodopa is still the gold standard. It's simply replacing what's lost and helping to patch that miscommunication in the brain that controls signals for movement. There's several different levodopa formulations, and I'll mention a few as we go through the talk today. Another category of medication is called a dopamine agonist, not directly replacing what's lost, but kind of tricking the brain into thinking there's more dopamine there, by simply binding to the same sites in the brain that dopamine does and influencing the signal again. And dopamine is endogenous, so it naturally occurs in the brain, but there's kind of a fail-safe mechanism which breaks the dopamine down to allow it to act for a specified time. There's two kind of compounds that are involved in that process. One is called the MAO and the other a COMT. By inhibiting those two enzymes, it allows dopamine to last a little bit longer. And so in patients who have those fluctuations of wearing off, we can use those two categories of medicine to prolong the effect of dopamine. And there's also amantadine. The exact role of amantadine in wearing off is unclear, but it has some role in improving dopaminergic transmission, so increasing the amount of dopamine. And it's very effective as well for dyskinesia, the abnormal excessive movement that can occur. Anticholinergics we used more commonly in the past and were pretty good for tremor control. I think with all the different medications now available, they're kind of less popular today. So I wanted to focus on wearing off and motor fluctuations because it's such a big functional consequence, but also it affects your ability to maintain exercise and mobility. There are general principles that we tend to follow, and these are all really patient dependent. It depends on the medical history, the medications you're taking, also the pattern of wearing off, and other medical problems and other medications you're on. But the general principles we use when a levodopa dose is not consistent and reliable are the following. First, we can just simply reduce the interval of levodopa dosing. So if you're on 3 times a day Cinemed dosing and you feel the symptoms come back 30 minutes or an hour before the next dose, adding another dose and shortening those intervals can be pretty effective. It's smooth, it's reliable, and it's a much more constant kind of treatment response, and of course the downside is an extra dose during the day and potentially exposure to more dyskinesia if there was a problem to begin with. Another option is to switch the type of levodopa to a kind of controlled release. It can be effective, except that the longer acting levodopa has more variability in terms of its absorption, takes a little longer to act as well, and it doesn't really affect the dyskinesia in a positive way either. For that reason, it can be a little more unpredictable. There's a new formulation of a long-acting carbidopa-levodopa called Rytary, in which the immediate release and the longer-acting release are combined in one capsule. I have a separate slide on that, but that's yet another strategy that helps to provide a more smoother response. And then away from levodopa, there's a few classes of medicines that I mentioned. So we can add a dopamine agonist, and they come in both oral formulation as well as a subcutaneous injection. Or we can add the inhibitors of the enzymes that normally break dopamine down. So an MAO-B inhibitor or a COMT inhibitor. And lastly, amantadine can also have good effect for wearing off, although typically we use it more for the dyskinesia. So more specifically, we divide the complications or motor complications in Parkinson's into two groups. That's wearing off for motor fluctuation and then the dyskinesia. And I mentioned the type of treatment strategies that we use to address each of these. I think the things to pay attention to for dyskinesia, amantadine can be pretty effective, including a newer extended release version that's better in terms of the dosing. And in terms of wearing off, we'll go through each of the categories again, and I'll point out the latest dopamine formulations, which include a newer oral formulation as well. So I mentioned one of the newer treatments that we use is the same levodopa, equally effective, but repackaged such that there's both immediate release and the extended release in one capsule. So the immediate release is, Cinemet is the other name, and typically kicks in roughly anywhere between 30 minutes and an hour. You'll start feeling that effect. It tends to have a plasma half-life of about 4 hours, meaning it stays constant in the bloodstream for roughly that period, and in the brain as well. And you'll notice the clinical effect for that long. Whereas the extended release doesn't quite reach the same peak unless you adjust the dose. It's a little more unpredictable as well. So Rytary is a novel formulation of levodopa. It has both immediate release and the extended release in one capsule. And each of them dissolve at different rates. So you still get the immediate release peak within an hour and the immediate response, but the breakdown of the extended release is kind of prolonged. And the goal for this new proprietary formula of levodopa is to have a more constant, kind of a smoother motor response with fewer doses. So you can dose it 3 times or up to 4 times daily, but have a similar type of effect. And it's really good for patients who, for example, if you have wearing off, even with 4 times daily dosing, to go up to 5 times daily dosing, this may help the dosing intervals and give you a smoother response. Another kind of strategy is to use the category of medications called dopamine agonists. And dopamine agonists are different from dopamine in that they're not replacing the lost neurotransmitter, but they're stimulating the same receptors and kind of tricking the brain into thinking that there's more dopamine available. There are a couple of formulations available here. So there's the oral form of dopamine agonist, which you can get in both immediate and extended release. But one of the reported causes for fluctuations are the GI complications in Parkinson's. So in Parkinson's, the gastric motility begins to slow down a bit, and the tablets are absorbed at a fluctuating kind of invariable rate. And this picture to the right shows a Cinemet tablet that's still in the stomach about an hour and a half hours after taking it. So most of it's absorbed in the small bowel, but if it doesn't get there because of slow gut motility, then the absorption's affected and the amount you get into the brain is affected. And so ultimately the response isn't as smooth as you want it to be. So one way of compensating, overcoming that, is bypassing the GI tract altogether. And apocrine or apomorphine is a pretty good option for that. So apocrine is a dopamine agonist. It binds to one of those dopamine receptors without actually increasing the amount of dopamine in the brain. It's very fast acting and it's injectable. So kind of similar to the way diabetes medication is administered subcutaneously. It acts very fast. So this begins to act within 10 to 15 minutes and at the latest within 20 minutes. And it's often referred to as a rescue drug because it acts quickly and it helps to abort those very unpredictable and quite dramatic wearing off spells. And a good example of those are like the morning achinesias. When you wake in the morning, it feels like you're on empty almost and it's difficult to get out of bed. Or the very unpredictable wearing off with freezing, when you suddenly freeze. And you know that a tablet of Cinemet will be effective but take an hour to work. Well, this is a good option because it works very fast, within 15 minutes. and it really only lasts up to an hour, at the most 75 minutes. So it almost forms a bridge between your levodopa doses. Certain patients have very unpredictable wearing off. So in the beginning, you may be able to predict that each dose is going to wear off an hour before the next one, for example. But later on, you notice that at just random times during the day, this freezing or tremor comes back and function is dramatically affected. And in the case of freezing and balance, it can lead to fall, so it can be quite dangerous. And in these situations, having a fast-acting solution like Apocrine is quite useful. Dopamine agonists have a different set of side effects because any of these medications, they work differently, they're pretty effective as well in the right setting, but all medications have a different cautions and mechanism with that side effects. Apocrine, much like the dopamine agonist, has some concerns if there are psychiatric symptoms like hallucinations. It can also cause a little bit of sedation. The one advantage of Apocrine is that the symptoms and the side effects will only last about an hour. But it's something worth considering if you're having unpredictable wearing off. Another category is the COMT inhibitor. So we spoke about two enzymes that are involved that break down the dopamine and essentially abort the effect of dopamine. So if we modulate that by inhibiting those enzymes, we can prolong how long the dopamine has its effect. And they're pretty good by adding about 15 or 20 minutes at each dose, so roughly an hour over the course of a day. There's three that are readily available. The one that's most available is COMT10. It's been used for some time, and a newer COMT inhibitor is touted for 2019 called Picapone, which is once daily dosing. They only work in the presence of dopamine, so they're not monotherapy. We usually use them with the levodopa, and usually combine them with the doses of levodopa. A big drawback to the COMT inhibitors is liver dysfunction because it's metabolized by the liver, and so that's one situation in which we tend to have some caution if that's a medical problem as well. Another category of enzyme is the monoamine oxidase inhibitor. This is an enzyme that's responsible for breaking down the dopamine in the brain. So as it breaks down, dopamine will no longer have that same effect. And so adding an inhibitor of that will also prolong dopamine and just smoothen out the response of the dopamine effect on motor function. The enzyme is involved in a number of neurotransmitters called catecholamines. Dopamine is one of them, but also serotonin and norepinephrine, and so it prolongs the effect of those neurotransmitters as well. There are a few monoamine oxidase inhibitors available. So Azilect and Selegiline have been around for some time, and they both have different kind of practical uses. Selegiline is broken down into methamphetamine, and so it has kind of a stimulating effect and can be good if fatigue is a big issue. It's used twice daily. A newer monoamine oxidase inhibitor is called Xadago. The three together add about roughly an hour of on time, so it's not as robust an effect certainly as dopamine is, which is the gold standard, but it's a good adjunct if you're still having some of the wearing off. And we spoke about fluctuations in the form of wearing off. Another obstacle to mobility can be kind of excess movement, which is the dyskinesia. Dyskinesia can also be quite functionally impairing, especially when it comes to exercise. And the one treatment we had used for a while is immediate release amantadine. Early on in PD, it was used really to treat the tremor, but it's also shown some promise for dyskinesia. The big caution for amantadine is cognitive function, so it can cause some sedation and impact cognition adversely, so we tend to be more cautious with patients who have some cognitive problems. More recently, there's an extended release version of the amantadine. So amantadine can be taken twice or dosed 3 times daily. The longer acting version is just dosed once at night and maybe has a slight small signal to increasing the on time in comparison to the older formulation of amantadine. So those are strategies that we currently use by manipulating oral medications, or in the case of Apocrine, the injection, just to work on that dopamine system. I'm going to talk a little bit about some of the newer formulation and newer options that will be available in the coming months to year. So the first is an inhaled version of levodopa. The chemical name is CVT-301, but it's an inhalation encapsulation powder that essentially is inhaled, and it's administered in that inhalation process, but it's very rapidly absorbed both in the nasal passages and in the lungs. And so the on time occurs within about 5 minutes, so equivalent really to the subcutaneous abelkine injection. And those improvements in function, either tremor or mobility, they persist for up to about 90 minutes. So this is the data from the clinical trial. These are the UPDRS, which is the clinical assessments that we do, the motor scales to measure all the motor impairments from tremor and slowness and walking problems. And the dotted line is the placebo group compared to the inhaled levodopa, which is seen at the bottom. The top graphic is after week 1, and the bottom after week 4. So you can see that there's an improvement between someone inhaling the placebo of the study and the inhaled levodopa, and that persists for a 4-week period. Another way to look at how effective the drug is to look at how much off time the two groups had. So again, the placebo group is in the dotted line, and the inhaled levodopa group in the solid line. And there's a statistically significant difference between the two, roughly about an hour and a half less off time during the course of the day. If you control it for placebo, about 3/4 of an hour more, or less off time on this group compared to the other group. So another novel therapy that's in a phase 2 trial right now is a subcutaneous levodopa infusion. This is a liquid formulation of levodopa. It's administered via a pump, and there's 2 sites. You can either have 1 infusion site or 2, depending on the patient situation. And the daily levodopa dose has quite a range as well, up to from 270 to 720 milligrams. It's not equivalent to an oral dose, so it's not a one-to-one change because the absorption once again bypasses the stomach. So we showed an earlier picture of how the tablets can be absorbed erratically into the blood levels erratic, and therefore the response is quite variable. This aims to address that by bypassing the whole GI tract and having the absorption subcutaneous, which hopefully allows for a smoother plasma level, so how much of drug gets into the blood system, but that's correlated to how much it gets into the brain as well. So the low dose infusion reduced the off time of those patients by roughly 2.5 hours without the dyskinesia. So it was reduced off time or on time without dyskinesia. It is a minor surgical procedure, and there's some local transient reactions that were involved, but this is a clinical trial that's currently completing right now. So I mentioned one of the indices to the variable response to dopamine is the serum level. So if you take a dose of dopamine and you measure the blood level, how stable is that can be an indicator of how stable the clinical response would be. At least we use that as a surrogate. And so these are 2 groups here showing, this is baseline, this is the baseline, and then 2 treatment groups. One is the subcutaneous levodopa, carbidopa, and the second is the subcutaneous levodopa, carbidopa plus Comtan, which is the COMT inhibitor. And both of them show a far greater stability in terms of the plasma level compared to their baseline levels, which is the primary outcome of the study. And this was monotherapies. They were used in patients who were not on any other, either oral levodopa or of the monoamine oxidase inhibitor apart from the COM. I'm going to touch a little bit on the surgery as well. So the medications are very effective. They can improve functional time. They can control some of the fluctuations as well as tremor. But in some patients, we have what's known as medically refractory, either tremor or dyskinesia or motor fluctuations. And in these patients, DBS can be a good alternative or good treatment option. Very briefly, DBS is a surgical technique and implants electrodes attached to a lead into specific brain regions. And there's 2 regions that we target in Parkinson's. They're called the GPI and the STN. They're connected to an impulse generator, kind of like a cardiac pacemaker, and that basically delivers an electrical stimulation to the specific circuits in the brain that are affected in Parkinson's. So when would we consider that? Well, first of all, patients who respond well to DBS often have a very good response to levodopa, and we use that as a good criteria. If you don't respond to levodopa, the chance of responding to the DBS surgery, or at least those symptoms responding to the DBS surgery, are far less. And there's one exception. The only exception to that is refractory tremor. So if your tremor doesn't respond to medication, it could still be a good target for the surgery. The other indication are the on and off fluctuations, so that inconsistent and erratic response to oral medications and poor function, dyskinesias that impair quality of life, and it's really important to have good cognitive function because it's one of the adverse effects of surgery as a whole. The flip side to that is who are poor candidates to surgery. Well, if you have a poor response to dopaminergic medicine, so if the symptoms don't get better with levodopa, the chance of them improving with surgery is kind of lower. And again, the one exception being tremor. We mentioned that dementia and cognitive function is a very important aspect that we look at, and the atypical Parkinsonism don't respond as well. In fact, there's some reports that they can decline. Lastly, we want all the neuropsychiatric symptoms like depression and anxiety or PTSD to be really well controlled. And of course, from a medical standpoint, including like cardiac and pulmonary function, it should be stable for a surgical procedure. So what are the symptoms that can get better with surgery? Well, it's primarily to address motor symptoms. It really is only for motor symptoms. So the slowness and the stiffness and the tremor can all get better, and it can do so by improving that on time and reducing how much off time patients have on medication. It can also reduce the dyskinesia, so to specifically target patients who have that excess movement. And the graphic on the right shows the two targets that we use. We use the GPI and the STN, and it really depends on your symptom complex and what symptoms we try and target as to which of those two targets we will use and how. And so that's it in terms of the surgery. I'm welcome to take any questions either about the medications or about the surgery before then.
Are there any aids for cognitive function?
So the question was, are there any medications or any aids for cognitive function? That's a good question. Specifically, from a medication and surgery standpoint, the pathologies, the process that's going on in the brain in Parkinson's is very different from other cognitive disorders, like Alzheimer's, for example, or frontotemporal dementia, and there's no good specific treatments to target that. There are clinical trials that use the symptomatic treatment that we use for Alzheimer's. One of them called Exelon that showed probably the better treatment response overall, but it is symptomatic, and that's really the only treatments that we have so far from a medical standpoint. But there are also good studies to show, as Dr. Juncos may have alluded to earlier, that exercise not only has a symptomatic and disease-modifying effect on the tremor and the mobility, but cognitive function as well. So patients tend to maintain cognitive function longer and to a better extent with exercise than those who are not. And I think that's true for just Parkinson's disease, Parkinsonism, and patients without a strict diagnosis over the age of 65, generally speaking. In terms of the surgery, there's no good surgical option for cognitive function at all. There's several trials, but nothing that's effective yet.
What about the use of CBD oil that Parkinson is on that list for legal use?
That's a good question. So far, there's very few studies to my knowledge, and Dr. Juncos can correct me if I'm wrong. There's very little data that it substantially helps tremor more than any of the treatment options that are available here. I think there was one study out of Europe that showed it might help the stiffness a little bit and anxiety, which is true not just for Parkinson's but neurological illness as a whole. But the reason I didn't mention it in this study was that the magnitude, how strong the treatment effect is, generally speaking, is not as good. It hasn't been shown to be as strong enough compared to these other medications here. So it's definitely, one of the mainstay treatment for Parkinson's as yet, anyway.
Sometimes when I take an over-the-counter antihistamine, I feel like my tremors are improved subjectively. Is there any documentation
Yes.
of a correlation between antihistamines and Parkinson's tremors?
Not specifically the antihistamines, but most of them have what we call an anticholinergic effect as well. And anticholinergics have been used for a long time to control tremor, so it is a treatment option. It's something we don't use because of the side effect profile and the sedation and the cognitive effect it can have, and because you're not directly treating the problem itself by as dopamine would be, for example. Okay.
Why do you think exercise helps?
Why do I think exercise helps? That's a tough question. I think Dr. Juncos showed some good scientific data about how exercise really improves the efficiency with which the brain uses the dopamine. So all these medication strategies focused on either increasing how much dopamine we have, preventing it from being broken down so it lasts longer, or kind of tricking the brain to thinking that there's more dopamine there. I think there's good evidence that exercise improves how we use what dopamine is available more efficiently. just allows us to use it more efficiently. And then there's some data that neuroplasticity, in which a neuroprotective mechanism can be evoked by exercise as well. But it's kind of somewhat complicated. And I don't have a really good direct answer for that, actually. Dr. English, to you?
Everything we talked about in the previous...
Okay.
I commend you on your knowledge on everything. I had a quick question. Is Parkinson's can be improved? Is there any relation to the spine abnormalities? Can it be improved? Can Parkinson's be improved by exercises related to spine?
So, exercises related to spine is the first?
Yes.
Okay. I'm not entirely sure which exercise. So when you refer to, are you talking about balance and gait exercises, for example? So any exercise that helps mobility will reduce fall risk, help movement as a whole, help your balance and walking, and so it will keep the symptoms at bay.
But is there any relation of Parkinson's related to abnormalities in the spine?
Not that I'm aware of. In fact, the pathology that we know of and the process that leads to Parkinson's and all the symptoms are all well localized in the brain. So very few changes, if any, changes in the spinal cord contribute. Now obviously if you have spinal cord disease or another separate process in the spinal cord going on that also affects your balance and your walking, then your symptoms are much worse and the disease overall is harder to control. But in terms of Parkinson's itself, the process that leads to the symptoms are all within the brain itself.
Thank you.
Doctor, can you comment on the use of benzodiazepine?
Sure. Sure, the question was for benzodiazepines. So there's really limited use for benzodiazepines to treat the motor symptoms of Parkinson's. So the tremor and the postural stability, for example, and the slowness. And in fact, because of the sedating effect of benzodiazepines, it can adversely affect balance and adversely affect mobility a little. But we do use it sometimes for the non-motor symptoms. So, if you've seen the graphic of how, even though it's a movement disorder, the motor symptoms are just one portion of the experience that Parkinson's patients have. They also have anxiety that can come with it, or depression, and also sleep disorders, and those are sometimes neglected. But among those are disorders like REM behavioral sleep disorder, where patients tend to act out their dreams, are active at night, or insomnia or anxiety. And that's generally when we reserve the benzodiazepine family for, like Parkinson, for example. But specifically treating motor symptoms, it basically has no role over and above the medication that we just mentioned.
Thank you.
Dr. Joash, always good to see you. Thank you for coming. But I'm doing some studies with some friends of mine around the country. Has there ever been any studies on the strength and the effectiveness of different manufacturers of carbidopa? Because right now I have 3 friends around the country where, and the drugstore gets whatever, when they order their medication, they get over which one is how many generic manufacturers are, they get over which one's the cheapest one, I'm sure. But I found out that one works better than the other one works for me. I have a friend in Pennsylvania that one works better for her than it does for me. And then I have a friend here in Cobb County that one works better, and we trade pills together.
Yeah.
And has there been any studies on the effectiveness? Because I'm concerned that some people go get their medication, their carbidopa is working good, you get a 90-day supply, and then you get another 90-day supply, and you just trust the drugstores giving you carbidopa. But when it's generic, you only have to hit a certain quality standard.
Yeah, well, that's a good question. To my knowledge, there's no data, there's no study that shows the difference in how effective they are, especially between different generic forms. So I'm not aware of any studies or any data, but that's a good point. Just from my experience, I've had patients tell me the same thing that you just noticed, that some generic will work less effectively, for example, in the brand. I don't have a good answer for that, because I don't think we have good studies to show that.
I think everybody needs to make sure when they get their 90-day supply, they look at who the manufacturer is, because you might have a different manufacturer. He only has to hit between a certain quality standard, and now when I order my carbidopa, I tell him I want this one certain one. And if he doesn't have it in stock, he has to order it for me. The one I use, I don't know the brand, the manufacturer, but it has a like a scripted R on it. It looks kind of like a cancer ribbon, breast cancer ribbon, like a scripted R. There's one that just has a slit. They cut it in half, and then there's one that is a football, like an oval football. And so I tried the other two, they don't work. And the one with the R worked for me, but then, like I say, this friend in Pennsylvania, another one of the one with the football worked for her.
Sorry, we got time for a few more questions.
Yes, could you speak to the issue of consuming protein, foods with protein around taking your carbidopa, levodopa? When I was prescribed that, I was told that it's important that you, because they're both amino acids, they'll want to compete to bind neurotransmitters. And so that if you take your medication, you wait an hour to eat protein. If you eat protein, you wait 2 hours to take your medication. My point is, when I mention this to people with Parkinson's, they just, I would say at least 90% of people just tell me that they've never heard that, and their doctors never mentioned that.
Sure.
So am I making too much of this issue?
So that's a good question. So levodopa, you're right, and protein tend to compete for the same site in the gut, so it can affect the absorption. And strictly speaking, if you have a problem with the absorption, you can separate them by 45 minutes to an hour. Now, how would you know if they're interacting? For example, if you take it with a meal and you started to notice that you're having delayed on time or failed dose, you could try to separate them, but it becomes very cumbersome, especially in advanced Parkinson when that issue is more prevalent. Trying to work your medication doses around the timing of meals can be very complicated, and so for the most part, we tend not to pay too much attention to that, practically speaking. Having said that, levodopa, if you take it without a meal, an empty stomach, it causes a lot of nausea. So more often than not, especially when you're starting medicine, you try to take it at least with a snack to try to offset that nausea.
And is it true that if you wanted your medication to kind of work quite quickly, like you're a little behind, that eating something sweet will speed that up? I've read that, but I don't know if it's true. Not that you want to eat a lot of sweets, but sometimes you're really behind the 8 ball, and it's like, I need this to kick in.
Yeah, that's a good question. I'm not sure if glucose or sugar per se improves the absorption. I know that taking it with a meal can help the nausea and help the absorption. But so the thing about the Parkinson fluctuations and the absorption of the tablets is that as the disease progresses, just like the slowness in the movements and your walking and your motor function, the slowness in the gut also tends to progress. Some patients more than others. And that's what leads to the tablets not being absorbed. It doesn't progress and move as quickly to the gut as it should. And it leads to erratic kind of absorption and the motor fluctuations. And one strategy which she mentioned was to separate the tablets or the dosing from protein to kind of maximize how much is absorbed. But that can be really cumbersome when you're on 4 or 5 times daily dosing anyway. And so instead of doing that from a practical standpoint, we try to use one of these other treatment options. So combining it with the extended release levodopa, which hopefully has a smoother absorption, or adding one of the non-dopaminergic medications to help with the fluctuations as well.
Doctor, what is the maximum regarding daily dosage or interval?
So strictly speaking, there's no maximum dose. We dose it to your threshold, which is dependent on a couple of things. Toxicity or side effects, so blood pressure can drop with high doses of levodopa, and we just want to make sure you're not symptomatic. And then dyskinesia, which is the other important aspect that we're trying to prevent. So if a patient becomes dyskinetic or has a drop in blood pressure, we try to adjust it. Typical ranges, so it starts at like 100 milligrams a day, so 1 tab 3 times a day, or 400 is a good starting dose. And it can go up to 5 or 6 or 7 times daily dosing, which is 1 to 2 tablets. You can go up to 1,400 milligrams a day as well. And the one thing I want to point out, since we're speaking about dosing, is that the other formulations of levodopa that I mentioned, Rytary being one and the controlled release being the other, they're not interchangeable in dosing 1-to-1. So if your physician, for example, notices you're having the wearing off and you decide it's a good idea to cut down on the number of doses during the day to make it easier, and so you go to Rytary, it's not going to be the exact same dose. It's dosed quite differently, and so to pay attention to that.
I just wanted to say I had been having a problem with my morning dose not kicking in. And I was taking it earlier and earlier before I had to be on, like 2 hours. And I finally started, I was eating it with Greek yogurt because I didn't have the nausea when I took it. And when I switched to eating it with oatmeal or taking it with oatmeal instead of Greek yogurt, it made a huge difference. I could reduce the dosage and it kicked in a lot faster.
Well, that's good to hear. Thank you.
So it worked for me. And one question though, I had gotten in the habit when I was taking more and more dosages of chewing them up before I swallowed them. Is that a bad thing? I thought that would make them absorb faster.
So it doesn't really have a dramatic impact on absorption, but if there's swallowing problems, we're okay crushing it out anyway.
Question about dietary. We have switched him onto that, and it's worked better than anything else. But Medicare is not covered. What is the process, or how long does the drug have to be on the use of your physicians for its actual coverage?
That's a good question. To be honest, I have not had too many problems with getting coverage. Maybe the folks from Impact can help better with that. In my experience, anyway, access hasn't been a big issue, so I can try and get that information for you. Especially if it's working, I think it shouldn't be a problem.
I probably have time for 1 or 2 more questions.
The consume of caffeine, cocaine, or marijuana affects the Parkinson?
That's a good question. So it was the effects of caffeine and then marijuana on Parkinson's. So I'll talk about caffeine first. So there were good studies a few years ago that showed that caffeine may actually slow down the progression of Parkinson's. That study, called Steady PD, has just closed, and I'm not sure the data from that. But at the very least, we think anyway that caffeine has some impact that may actually slow down what goes on in the process in the brain. It's not to the extent that the more caffeine you drink, their symptoms will probably be better, but it's probably long-standing exposure to caffeine. So if you drank a lot of coffee 10 years ago, 20 years ago, it may improve the outcome. What that means practically, I wouldn't put too much emphasis on that. Don't start drinking a whole lot of coffee now. It's gonna help the symptoms at all, except that caffeine sometimes worsens your tremor. So just to pay attention to it because every patient's different in that regard. The question about CBD or marijuana is a little more challenging to answer. We don't have a lot of studies in Parkinson's. There's way more literature and studies in the rest of neurology, like multiple sclerosis and epilepsy. And from those studies, they kind of suggest that marijuana has a protective effect in certain areas of the brain regardless. But it hasn't been proven again in the Parkinson's population because the diseases are different, so the state of the brain is different as well. I can tell you a few studies that have been done. There was one in France that looked at tremor that maybe was a little better in patients who took the CBD oil compared to the placebo. But overall, the effect of the marijuana was not as robust and not as strong as the medication classes that are proven beneficial and that we use routinely. So there's not enough evidence to routinely recommend marijuana now anyway.
Okay, one more question here in the back.
Well, talking about the use of marijuana, are you referring to just the CBD oil, or are you referring also to one which has a THC component?
So all the studies, I believe, were done in only the CBD oil preparation. I'm not familiar with the studies that included the THC, so I'm not really sure about those.
You can put in a plug for the next conference from PD Gladiators. We may actually focus on the next conference for Parkinson Gladiators, which will be, Annie will announce it in time. They'll probably focus a bit more on this topic, so don't give up on it yet.
Yeah, the Parkinson's Foundation, interestingly enough, is actually doing a cannabis convening, a meeting out in Colorado early spring. Hi. Are you going? No, I'm finished. No, I'm just kidding. But we are actually planning, as Dr. Juncos said, we're actually planning on focusing our spring educational symposium on this very topic, in addition to some other sort of alternative therapies, just looking at, maybe debunking certain myths and really evaluating what's out there and what's factual. So stay tuned. Well, thank you so much, Dr. Lazarus. All right, well, we're going to take a break. Feel free for the next 15 minutes, use the restrooms. They're over here to my left. We do have lunch, but if you could, to avoid people standing in line, maybe we'll do this section first. If you guys want to get up and get your lunch while you guys use the restroom and mingle with exhibitors, we'll get you guys fed as quickly as possible. And then we're going to hear from some of our Parkinson's folks in a minute. They're going to tell us about their exercise experience. And then he's going to, my question for you is going to be, with the recent shoulder surgery, how you overcame the transition from exercise to not exercising to recovery, and how that's made you feel.
Thanks, Amy. If any of you are thinking of taking a 3-month vacation from exercise, don't do it. Don't do it. I had rotator cuff surgery. I had rotator cuff surgery. What do you stand up?
Hold up your mouth.
Hold it up to the mouth. I had rotator cuff surgery about 2.5 months ago. One of the tendons I tore very badly, and it took longer for him to do the surgery, but he said, I think I can get you to recover, but it's going to take you a while, and you cannot do literally any exercise on the left side of the body. Well, if you can't do one half of the body, it's very difficult to do the other side of the body. And I noticed in the first week that after surgery, that I was losing some strength in just little things. I didn't have trouble turning in bed at night. Some people do, but I didn't. I started having trouble doing that. Never had anything that had to do with freezing, but I noticed that maybe once or twice a day I would start to get that. I noticed that I really didn't have tremors to any great extent. I started to get that. So after about a month with literally no exercise, the only thing he said I could do was walk. I really felt like I had deteriorated substantially, which was not the case. I go to boxing and hopefully be back to boxing in another couple of weeks, but it was one of those things where you could just feel your body deteriorating without the exercise. And it was clear to me that that was a component of not having the rigorous kind of exercise that I've been used to for years. I've had Parkinson's for 21 years, and it's amazing how little effect it was. My neurosurgeon said, you're my poster child, because nobody could tell at that point in time that I even had Parkinson's. But over the last 2.5 months, there's a clear relationship. Even though this isn't a scientific study, I can tell you completely that without exercise, it's making all the difference in the world in trying to keep myself active and engaged and being able to do the things I want to do. So hopefully we'll see how long it takes for me to get back into the groove. It'll probably take a month to 2 months before that happens, but I can just tell you that for me there's a unbelievably direct correlation between lack of exercise and the impact of Parkinson's on the body.
Thank you so much, Bob. And Bob, I really, when you say poster child, I think when people heard you had it for over 20 years, you heard this, you're doing incredibly well. Thanks, Bob. Well, Alice, it's my turn to pick on you a little bit, and sort of a similar question to the one that Bob answered. I know that I would love you to answer, when were you diagnosed, and then how did you overcome a similar kind of a recent injury, and what did you do to really stay active and positive during that time?
Hi, I'm Alice. It's so funny when I heard you say 20 years, and when people ask me how long I've had Parkinson's, it's like I'm almost proud to say 12 and a half years, because we're running a war, and we're still in the war. It's like David and Goliath, and we're still here, so I think that's awesome.
Thank you.
I had knee surgery, I guess about a little over a year ago, and then I messed up a tendon in my finger, and now I've got, or nerve in my finger, and now I've got tendonitis in my wrist, so it seems like I'm always coming up with some kind of injury. But I try to stay active. And from the very beginning, when you're in bed, and then the next step is to get to the chair. And then the next step is to walk to the mailbox. And then the next step is to cook dinner maybe. And then you're going to build up. And eventually you're going to see a window. A window where, you know what, I'm feeling a little bit better today. Put on your shoes and get out the window. That is the time. And little by little you'll notice that your stamina is increasing. More windows are opening because, like you said, you start with little things and then you grow and you get back into your exercise pattern and you feel better. Make sure that you have a cheering team, whether it's your friends, whether it's your relatives. If you go to a big surgery, you got to have somebody to cheer you on. I have my husband and my girls, and this is what my girls made me. They made me Alice's victories, and every time I did something, they gave me a star. Wow. And then they bought me a present with my money. But these little things, it means something. It means people are supporting you. They're behind you. So thank you. Another thing too, nobody's brought it up, so I will. Constipation. When you have surgery, you not only have the constipation from Parkinson's, you have the narcotic constipation, and it's awful to get your medicine through when nothing else is getting through. So I brought, if anybody wants afterwards, my doctor gave me a homemade recipe, and I brought 30 copies if anybody wants. It's all natural, you know, lots of oats and stuff like that. So it's something that you can try, and I'm happy to share it. I'm trying to think what else I wanted to say. I guess that's basically about it. But then the last thing is my girls and I, whenever we do something, whenever we made a milestone, they say we're all in this together, is we raised our hands and we said, you know, yay for us. But the yay for us turned into a V for victory. So all of you who are here for victory, raise your hands, a V for victory.
Good job.
Thank you so much, Alice. I'm going to pass it to Lloyd if you don't mind. Thank you so much for sharing that. Lloyd, I'm going to ask you first when you were diagnosed or how long you've had Parkinson's, and then what therapies and resources help you stay active.
I'm going to stay seated. So I was diagnosed in 3.5 years ago when I was 63. I'm 66 now. If you would have asked me where I thought I'd be at this point when I was first diagnosed, I didn't think it would be here. I really didn't know what was going to happen. It seemed like a death sentence at the time. So relatively speaking, I'm a hell of a lot better than where I thought I might be. And it's attributable to, which is what your question was about, what do I do? So I'll admit, I started out delayed taking Cinnamate for the first 2 years, thinking I could try exercise, and I did, and I was doing okay, but finally got to a point where the symptoms were bothering me enough that I decided to try Cinnamate, and I'll have to admit it felt like a miracle drug. It really did subside the symptoms. I was able to exercise a lot more, be much more active, more comfortable when I was out and about, and continues to be a huge part of what I do. So I find that without the drug I couldn't exercise as much, and with the exercising obviously makes me feel stronger, more mobile, have greater sense of mobility than I did in the past. The other thing that Dr. Juncos highlighted, which I think was important, I go to the boxing class. When I joined it, I just went there because I heard it was probably going to be a good thing for me. But I learned that the camaraderie aspect of it was something I was really unexpected. So I found that I wasn't alone in this battle, that there were many other people trying to do exactly what I was trying to do, all at different stages along that, but we shared it. We could even laugh and have some fun at times. That was a reward I hadn't expected to get out of the boxing class. I hadn't been to an exercise class probably in 20 or 30 years, so it was really great. Also, an offshoot of that was a small support group, an informal support group of some what now becomes some friends. We have lunch usually once a week, talk about what we're doing, how we're doing, what we're trying, sharing things with each other. That's been great. The other thing that's been an important part of what I do is also looking at nutrition. So I've done a lot of reading, because you don't get a lot of that, I'll admit, from traditional medical folks. So I decided to do a lot of reading on that, and I changed my diet and take supplements to try to take what I consider to be a very holistic approach to trying to deal with this disease and disorder. So that's what I do, and so far it's working pretty good. I don't know what it would have been without doing all these things. What I do know is I'm here and I'm feeling pretty damn good, relatively speaking. Thanks.
Lloyd. All right, Martha. All right, if you want to tell them when you were diagnosed, or how long you've had Parkinson's, and then how do you keep your exercise regimen fun and sustainable?
I'm going to stand up because I'm short. But I was diagnosed last year. I'm age 61 now. And shout out to the South Side. I'm from the Newnan Peachtree City area. I do exercise for all the obvious reasons for Parkinson's, but I also do it because it helps my mental state. And I was, just the medications can make you down, and then on top of you're not sure what your future is. But my main thing is I go to water aerobics in a therapeutic pool that's a little bit warmer. It's for, well, they called it arthritics, but now it's for just about anybody. And so most of us are older. I have two 93-year-olds in the class that come in a walker and they get in the pool and proceed to kick the rest of us hoo-honeys. And I want to be them when I grow up. But it's a good camaraderie. It's really good to keep your head connected to your hands. In my case, my hands just don't listen to my brain. And so anything I can do to have fun and be with a group is what I like to do and keeps it fun. Find a pool, find anything. There's all kinds of things in your community. You can always contact us at the Parkinson's Foundation to help you find other things as well. There's something called Aging with Grace. There's something called, in Newnan we have something called Exercise as Medicine that just helps people with brain dysfunctions. We're not really dysfunctional brain-wise, but it really helps to connect our hands and our brains to everything. I had an endoscopy yesterday and the anesthesia's messed me up. That's why I'm shaking today. But anything you can do, anybody you can call to help you get a group to understand what you're going through, but just to make it fun. And the last thing I do is I go to the toy box. Bouncing a basketball is great. Having something like this just to toss in the air or just, help you with your tremors, it's great. My newest thing is a paddle ball. It's hard, but keep working on it, and it's something that can help you as well. Any questions, let us know, but we're here for you, and you're all my heroes because you're all here, and you're all here to help each other. And thank you so much for coming and helping us.
And last but not least, we're going to welcome Denise. Not going to let you do it. Okay.
That's right, Denise.
Thank you. All right, Denise, you have an interesting story. You've received 2 diagnoses within a year of one another, MS and Parkinson's. So, Denise, this question is for you, and sorry, if you would tell them how long ago those diagnoses were, and then we'd love to hear more about how you feel about establishing early exercise habits and how important that has been to your success.
I was diagnosed 5 years ago with multiple sclerosis and a year later with Parkinson's disease. So I got what you call a double whammy. I was very blessed though because both of my neurologists, Dr. Barry McCaslin and Dr. Juncos, work together, and they both are huge supporters of the PD Gladiators Parkinson's Fitness Network. So I immediately was told about the benefits of vigorous exercise before I even left their office. I said to Dr. McCaslin, okay, so which is the toughest of the different exercises because I want to get the most benefit, and he said boxing. So I immediately got my phone out, looked up the closest one, and it was LDF boxing. Luckily, it was only 5 minutes away from his office, so within the next 5 minutes, I was able to meet with Paul Delgado, who literally welcomed me with open arms and said, don't worry, we'll fight this together. And he kept his promise. At that time, I was still working, and everybody knows that stress is probably one of the worst things for PD symptoms. And I was at my second appointment with Dr. Juncos, and I said to him, my job is just driving me crazy. I'm traveling all over the world. I was a fashion designer, traveling domestically, working insane hours. And I just blamed all my symptoms on my job, thinking I'm just tired and overworked. And I said to him, it was a Wednesday afternoon, and he said, I really think that you're right, that you need to retire. This is just not going to work with your PD symptoms. And I said to him, well, what do you think I should do? He said, retire on Friday. And I said, no, come on, for real. And he said, no, for real. And he said to me, if you could take the energy that you put into your job, because obviously you're successful, you're a vice president of a company, and take that energy, that 5 days a week, and put that into exercise, I promise you, you will improve. And he was so right. I exercise now 5 days a week with the boxing program. And I've attended over 200 classes this year. And a lot of you might say, wow, that's just obsessive. But I get up every morning with the determination that I'm going to make the best out of every single day. I'm not going to just, slough off and say I'm tired or I don't feel well. I find that the more I exercise, it's addictive, the better that I feel, I promise you. I was a total mess when I first got diagnosed. I had probably 12 of the major symptoms of Parkinson's disease, and I can honestly tell you that after 4 years of boxing, I have improvement in every single one of those symptoms. I also have the privilege the last year of being the vice chairman of the LBBF boxing program, which means I had the privilege of meeting over 200 people with Parkinson's that are our members. And everyone tells their story, and everybody's individual. You mentioned about how everybody is unique. It's sometimes referred to as a snowflake or the fingerprint disease, because no two of us are alike, even though the symptoms are the same. And everybody's told me lots and lots of stories. And I could tell you amazing miracles that happen in our class. And it's all from the exercise program. Charles Alocio, who's over there, started out in our 3-4 class, and within months, he's now moved to our second class. 1, 2, 3. Brian Jensen, the trainer that you saw before in our demonstration, he started with symptoms of dyskinesia at the age of 10. It took 6 years for him to be diagnosed, and Dr. Toulon finally diagnosed him at the age of 16 and did DVS on him. Brian is the living proof of what exercise can do to help the symptoms of Parkinson's. You see, he's now trains people in boxing seven days a week. And he has, other than his softer voice, he shows no signs of PD. So he is probably the epitome. He's our inspiration. In class, if we say, I can't do that, and he'll look at us and go, for real? Like, come on, that's impossible. I wrote down some notes. I want to make sure I cover it all. Oops, thank you. So why boxing? What's really important to know about our discipline, I know there's so many other wonderful disciplines within the PD Gladiators Fitness Network, but what's so important about boxing is that it's the most demanding sport. And again, if you want to talk about vigorous exercise, why not do the best? PD causes the loss of so many of the same elements that boxers actually concentrate on when they're training. Agility, footwork, balance, focus, range of motion, strength, endurance, breathing. I remember before I started boxing, I couldn't even make the bed and walk around it without huffing and puffing. And now I'm totally functional. I couldn't push a vacuum, and now I have a 3-story townhouse and I actually vacuum the staircase. It has totally changed my life. And so with the early intervention, it's like anything else, it's very logical. Like Annie said, there are 168 hours in a week. If you can't find 2.5 hours a week or more to dedicate to giving yourself the best opportunity and benefits to help yourself fight these PD symptoms, it's just a natural, logical conclusion. Thanks.
Thank you guys so much. Let's hear for our panelists.
Denise, do your doctors know that you are now working more than full-time?
Yes, yes they do. And that's another thing about the cognition part of it too, we talked about a lot. I was really struggling before I retired. It was very hard for me to concentrate. Dr. Juncos and Dr. McCaslin were very aware that it was really hard for me. Now I'm working harder, and it's easier since I've been exercising. It's just amazing the difference.
Yeah, I took it on in January of last year, and so you can pretty logical probably the clinical outreach. Our primary focus is neurologists. We try to also do some work with physical therapists as well, and you can see what our objective here is to make sure that they're aware of the importance that exercise plays in the therapy for Parkinson's, and make sure that they know about our network, because we want them, that's a good place for them to point the patient to get them started as early as possible. The doctor has commented at the earliest outset, as soon as they're diagnosed, they should begin exercising of some sort. Physical therapy, from my perspective, is the best place to start that. That's what I did as soon as I got diagnosed. Within about 2 weeks, I started a physical therapy program for about 4 weeks. A lot of get me on the journey. And that person that led that really got me started with TD Gladiators. I think before I got out of that physical therapy, I had at least 3 or 4 brochures in my hand to make sure that I didn't forget about it. And as soon as I retired, actually, I got involved again. Boxing program will be 2 years coming up in February. So I use my own experience when I go see the neurologist, and at this point I have a small team of people that are working with me. Is Mark Claude is in the back of the room. What we go do is basically get into the office. We don't often get a chance to see the neurologists themselves, but we see somebody, the office manager, someone there, giving them information about our program and make sure that in that is included is some research information in case they're not fully on board yet with why exercise is so important. Give them one thing to look at as well. Then we have brochures that we hand out that we want them to give to the patients to make it easy for them. So that's really what we do in that. At this point, as I mentioned, there's Mark and myself, and so we can't really get around to see every neurologist in the area. I wish we could, but we're going to expand hopefully our work next year. I actually have an opportunity for you folks to help out with this, an easy one, an informal activity. I'm calling it an exercise ambassador. And all I'm asking you to do is when you go in and see your doctor, have a discussion about exercise, what you're doing, what benefits that you're getting out of that exercise. So they see if they've got any suggestions for you. Then ask them some questions about what they're doing with other patients. Are they a proponent of exercise? Do they know about our program? Do they have brochures in the office? In your paper that you received at your seat, there's 2 slides. Has a cover slide, and then my contact information is on this. So if you're interested in doing this, it's not a formal job or anything. All you have to do is when next time you go in, and every time you go in and talk to your neurologist, just talk to them about what you're doing about exercise, see what they are doing with other patients, and help us to carry this message forward about how critical this is for therapy for PD. So if you're interested in doing it, please contact me. And no formal, we got brochures to give you. If you don't have anything, all you have to do is contact me. We'll get information out to the neurologist, make sure that they've got information they need about our program. Thanks.
All right, so it's not magic. How do neurologists and patients hear about PD Gladiators Fitness Network and the Parkinson's Foundation? It's because of our clinical outreach committee. So again, as Lloyd mentioned, they can't be everywhere all the time, so any help is greatly appreciated. Joash, physical therapist, she's been involved with PD Gladiators since its inception. She's now involved in our Parkinson's Foundation Georgia Advisory Council. She's actually tasked with keeping all of you guys out in the network safe by working with the instructors, offering continuing education. So she is an expert at what she does, and I will let her. I'm going to cue this up for Amy.
Okay.
Hopefully it won't
Thanks, guys. Let me put my timer down and my water. Thank you for hanging out for the last but not least session. I will make this relatively painless and quick so that we can answer any questions and get out of here. And I'm also parked in a 2-hour parking spot, so I'm pretty sure I have a parking ticket at this point.
You want me to move your car?
That was okay. Okay, so what I'm going to talk about is just how we are going to tie all of this in. Specifically, how are we going to tie neurology into physical therapy to community wellness? So I'm going to specifically talk about the roles of each one of those areas. Because I am a physical therapist and I strongly believe in it, my conversation is going to be a little bit heavier on the physical therapy side of things. So I apologize for those neurologists and fitness instructors out there, but I also find that there is still some confusion in the community about the role of physical therapy versus general exercise. So I hope to answer some of those questions today and clear it up for you. We're going to talk about when you need to return back to your neurologist or when you need to return back to your physical therapist, especially if you're heavily involved in the community exercise programs. And then we're going to link it to a case study so it makes a little bit more sense. So you want total package care, right? At the top of that is your neurologist or your movement disorder specialist. Also on your team, you want a sleep specialist, a psychiatrist, a neuropsychologist, and your general practitioner. On the other side, you want your rehab therapies. You want a physical therapist, an occupational therapist, and a speech therapist on your team. Today we're only talking about PT. You want a social worker on your team. You want your fitness instructor and your group wellness classes in your team. And you also want support groups and community events like this on your team. So again, we're just discussing neurology, PT, and community wellness and how those players should be interacting together to provide top-notch care to slow the progression of the disease. So, just very briefly, the role of a neurologist is to diagnose disease or conditions. They do this through clinical diagnosis, through taking all of the signs and the symptoms. They can also order additional tests and scans and imaging to confirm that diagnosis. They interpret the results and then they get back to you and educate you regarding the diagnosis, the prognosis. They are with you for the course of the disease. They can link you to other healthcare professionals. In order to go to physical therapy, you have to have an order from your neurologist. They're also very vital in prescribing the medication, knowing what medications react with other medications, whether it's Parkinson's meds or other medications that you've been prescribed. And then they're very vital in the recommendation and screening process for DBS. This is the very least of what they do. They also do research and write papers and speak at conferences and et cetera, but this is the clinical aspect of their job. A physical therapist is going to evaluate your current level of function, compare it to your previous level of function, look at your goals for future level of function, and help you get there. We are movement specialists. We analyze movement. We look at where the breakdown of movement is or where your breakdown in your functional mobility tasks are, which we're going to talk about in a second, and then we address that. We determine a plan of care, typically through exercise, that addresses your impairments, your function, and your goals in order to make movement more efficient, safer, and make your quality of life better. We can recommend referrals to other healthcare professionals or recommend you go back to the neurologist. And we also are a big player in linking you with the correct community wellness program. Some people are great for the boxing program. Other people need that one-on-one training from a personal trainer, right? So I do a lot of that on my discharge planning. So what is functional mobility? I've talked about this a lot in my other lectures. Functional mobility is anything movement-wise we do in our daily life. This is what the physical therapist is going to help you with. Walking, balancing, getting out of the chair, getting out of the car, rolling over in bed, sports, boxing, golf, getting in and out of a booth at a restaurant, reaching, okay, et cetera, et cetera, et cetera. So your physical therapist is looking at those functional mobility tasks, and they are specifically addressing the size and the speed of those tasks. Where maybe do you have some muscle imbalances that are affecting your ability to do these tasks? They're looking at the quality of your gait. They're helping you decrease freezing of gait through strategies, or they're helping you decrease your shuffling of gait to make you more efficient and faster and safer. We're looking at posture and postural awareness, teaching you where is your body in space. A good physical therapist, and we're now all getting on board with this, is working more with vision and vestibular system because those are our two biggest balance systems. Even things like breathing, a physical therapist can work on to help decrease low back pain or decrease anxiety. It can also help with that vocal production for a loud voice. So your physical therapist is going to look at you and ask, how are all of these symptoms, either together or individually, impacting your ability to function and function well and safely? Community wellness. Their role is to implement a fitness and a wellness program to keep you moving, to keep you strong and flexible, to keep your physical capacity in a good range. They will assist you and modify any exercises for you if you have safety issues or pain issues or precautions. They are going to encourage challenge and vigor and intensity, and as we just saw in the last presentation, fun and community. And then we hope that they're encouraging their clients to use their movement strategies that they've learned in physical therapy so that they can get the biggest bang for their buck in the class. And then it's important for the fitness instructor to know when to refer back to the neurologist or the physical therapist, especially because most of the time the fitness instructors are now our eyes. They are our eyes on you guys. They're seeing you guys multiple times a week. So they need to know when something's not quite right, and let's get back to the neurologist or the therapist. So when to contact your neurologist? Very briefly, if something new happens that's interrupting your quality of life or ability to move. So whether your symptoms, your Parkinson's symptoms suddenly or acutely change or worsen, if you have any new onset of symptoms that's impacting you, such as new pain, new weakness, new bowel or bladder issues, new confusion. Anytime you have a question of medications, and that includes supplements, that needs to go through your neurologist. And again, the neurologist is the one to prescribe the order for the physical therapy. When to return to PT? Every 3, 6, or 12 months, depending on your level of ability and what you and your physical therapist decided. You need to return back to physical therapy, though, if your balance or walking or your ability to move in general, maybe get in out of the bed, on and off the couch, is changing or worsening or declining. If you have pain and it just won't go away, right, and it's impacting you. And then, if your motivation for exercise is decreasing, you just need a swift kick in the butt, right? So I kind of joke that my job is composed of 3 parts. 1, I'm a physical therapist. 2, I'm a marriage counselor. And 3, I'm a cheerleader, okay? And I don't mind, because it's so important, right? I don't mind bringing my pom-poms to work. So just a takeaway message. Exercise does not replace skilled physical therapy, but it's used as a supplement and an enhancement to keep you strong and keep you flexible and keep you moving between episodes of therapy in order to delay the progression of the disease. So, quickly, case study, because real life examples make the most sense, right? I have an 81-year-old female with a history of Parkinson's for 5 years. She also has a history of essential tremor. She has hypertension, hypothyroidism, diabetes, and osteoporosis. She's retired. She lives with her husband in a senior living facility. She enjoys knitting and going to her book clubs. She goes to our Ageless Grace class once a week. That's in our network. And she rides her stationary bike 10 minutes every day. She comes to her neurologist with worsening tremor bilaterally. The tremors are worse when she's off her meds because she forgets to take them sometimes. And the tremors are worse with stress and anxiety. Her gait pattern is worsening. She's having more shuffling of gait. She's had 4 falls in the past 4 weeks, which is new for her. 2 falls were forwards, 2 falls were backwards. She has more difficulty getting in and out of the bed. Her husband now has to help her at night when she's more fatigued. Sleep has improved since her last neurology visit. She's had no change in cognition or memory. Her mood is staying about stable. She's noticed some changes in swallowing, maybe a little bit of choking with thin liquids, not sure. And she's got right hip pain. So the neurologist found that yes, her tremors are pretty bad, but she's off her medicine today and she's got white coat syndrome, right? She doesn't have any change in cognition, mentation. She has some mild depression, but it's staying steady. She has no hallucinations, so her medications are in that sweet spot. She's got some minimal rigidity on the right side. She's got some slowness of movement, stooped posture, shuffling gait. She scores a 33 out of 108 on the UPDRS score, which is a scale that the neurologists use to measure symptoms. His plan is to increase her medication to 1 Centimet 4 times a day, and she's going to stay on her dopamine agonist patch as she had been in the past. He referred her to physical therapy for gait balance and hip pain and ordered a modified barium swallow study. She's to return to him in 6 months. When she came to physical therapy, her goals were to improve her walking and balance in order for her to go out into the community and go shopping with her daughter twice a week. She also wanted to improve her balance, especially in her apartment in narrow spaces. She wanted to be able to get in and out of the bed independently without her husband helping her. On my observation, I found that she had stooped posture in both sitting and standing, but she could get out of it when cued. She had slow movement and small movement, especially when she was transitioning between activities. She had limited range of motion in her neck, making it difficult for her to turn her head or look up or down. She had bilateral resting hand tremor, masked face, low volume of voice, but she was able to self-correct it because she just took loud therapy. She was not using an assistive device, and she did not want to use an assistive device. And her gait quality had declined. She had bilateral shuffling, decreased upper extremity swing. She turns unblocked, meaning she does not dissociate her head from the rest of her body when she turns. She had a lot of imbalance navigating a crowd and other people in the hallway. And then I noticed she walked with a limp because of right hip weakness. So that was probably where her pain was coming from. These are some of the objective testing I do, the objective measures that I do in the clinic. I'm not going to go through them because they're pretty scientific, but 6-minute walk test, she's basically below normal on all the tests. The mini best test is a balance test. This shows she's high risk for falls. The cognitive tug is a dual task test. She's unable to walk and count at the same time. She has 2 incidences of falling backwards into the chair when she tries to rise without hands. Her balance confidence is a 56%, and it took her 2 minutes and 17 seconds to get in the bed, roll over to the right, roll over to the left, and get back out. 2 minutes. That is painful, okay? So this is before therapy. So during therapy, what we did a lot more than this, but I was not going to put anything else on this slide. We worked on her walking quality. We worked on her posture. We worked on long steps, landing with her heels. We worked on dynamic calf strengthening for that propulsion, for that push-off to counterbalance the shuffling of gait. When she got that down, we added things. We added visual scanning. We added her carrying items. We added her backing up in narrow spaces and turning in narrow spaces, simulating her in her apartment environment. For balance, we did multi-directional stepping with reaching, right? That was one of the areas that she had the fall. And then we worked on step balance reactions. I put her in our harness. I taught her how to step with a large amplitude, and then I pushed her around the gym until she could catch herself from falling. When she could do that, I added a distraction or a thinking task or had her carry something, and I kept pushing her around until it was learned. We worked on in and out of the bed with larger and faster movement. When that was easy, I added blankets, sheets, and distractions. And I also worked on her neck some because the rotation piece was limiting her ability to scan her environment to navigate obstacles. So we did some soft tissue mobilization, which is the fancy medical term for massage, and some gentle range of motion. She has osteoporosis, so anything like joint mobilizations or strong stretches is contraindicated. So the most important piece of this, though, is the motor learning piece, because we wanted her to relearn these skills so they were automatic again in her life. So the activities were important to her. They were goal-directed. They were specific to her environment, her apartment, her bed. They were challenging. When the activity was easy, we added something. And we repeated the same type of activities over and over. To get her to buy in cognitively, I had her to tell me, how many seconds is it going to take you to get in and out of this bed? How did that feel? How did that movement feel differently than the last movement? Right? What did you do well in that task? And then I gave her positive feedback in order for her brain to know that when she moves this way, it's normal and good and effective and safe. Okay? And then we trained her husband. Yeah. That's another lecture on that one. These are her outcome measures. They were pretty significant. She went from below normal to above normal on everything. This is not unusual. This is what happens after an episode, a bout of therapy. Okay? She went from a high fall risk to a low fall risk. She was able to dual task in 14 seconds. She can stand up from a chair without falling backwards. Her confidence in her balance improved. You guys, she went from 2 minutes and 17 seconds to 7 seconds getting out of the bed. All right? I know you want to clap for her, don't you? Yay! Pretty powerful. So, after physical therapy, she is to return to her neurologist in 6 months. She's to return to PT in 6 months. She is going to go back to her Ageless Grace class and use those larger, more effective movements that she's learned in therapy. One plug about Ageless Grace. I love it. It is a class in our network. It is so fun and so playful and creative. It's 21 tools based on brain-body connection, and they have names like Spaghetti Spine, Dance Party, Juicy Joints, Gentle Geometry, and every time it's different and it's done to music. If you haven't been, I highly recommend you check it out. So, she went back to Ageless Grace one time a week, and I got her a personal trainer from our network. I talked to her personal trainer about continuing some of the activities we had started in therapy so that she could keep the improvements that she made in therapy, as well as, some other goals that the patient had in mind. We also discussed with the personal trainer the contraindications, so the high blood pressure, the osteoporosis, the diabetes, things that the trainer should keep in mind when exercising her. So, at her 6-month check-in, she came back to the neurologist. Tremors improved. UPDRS is improved. She's had no falls. He referred her to PT and did not change her medicine. I retested her. Her objective measures had stayed about the same. She was in and out of the bed fine. I saw her 4 sessions to update her home exercise program and sent her back to her personal trainer and her Ageless Grace class. So the takeaways. This is a multifaceted condition requiring a healthcare team. You have to have an ongoing cycle of care for the best prognosis. Neurology to physical therapy to wellness to physical therapy to neurology, ongoing. And the healthcare professionals and the fitness instructors must communicate with each other because it is in the best interest of their patient and their client and you guys. And together, we all want the same thing, right? To slow the progression of the disease. So we're all working together. And this is my assistant, Ruby, right here. She was tired of my working from home and wanted to go for a nap. So if you guys have any questions, I think there's time for 1 or 2, and I'm going to stick around a little bit at the end of this, unless I have a parking ticket. So, yeah, does anybody have any questions? Yes?
I just want to let you know, I was in physical therapy for a couple of years due to RA, but it was my physical therapist that discovered that I might have Parkinson's.
Okay.
And sent me to the neurologist.
Okay.
Which I think is brilliant.
Yeah, that's very good. And you got on top of things earlier then, probably, didn't you?
Well, yes and no. I think fairly early, but I probably had symptoms, had I known before, that could have been perhaps picked up.
Yeah. Thank you. Anybody else?
Questions for Amy?
You guys are ready to go. Totally understand it. Like I said, I'll be around if you have questions, and thank you.
Does anybody